my first job is to introduce those two who are welcoming you on behalf of WHO, Willie Palm and Natasha Azzopardi-Muscat. I never like to get people's names wrong. So the two of them will say a few words and then we'll move to the technical content of the meeting.
Good afternoon, everybody. Good to see so many people, familiar faces and also new faces. And also I hear that many people are online. So on behalf of the WHO office here in Brussels, I would like to welcome you to this event on rethinking health financing policy in the age of uncertainty. I would like to welcome you on behalf also of our director, Ms. Oksana Domenti, who could unfortunately not be here today. Actually, she is in Geneva with a delegation of the European Parliament's Public Health Committee to attend the closing of the World Health Assembly. And as you know, the World Health Assembly this year was a historical one with the agreement, the pandemic agreement that was adopted last week, and also the discussions on the future of WHO. But let me also remind you that on Saturday, actually, the World Health Assembly was discussing the progress on the Agenda 2030 on Sustainable Development Goals, more specifically on universal health coverage. And in that meeting, WHO reported that we are off track on reaching the ambitious goal of having 1 more billion people benefiting from universal health coverage, which goal which was set in 2019. And actually, according to the data, WHO reported that only 43% of that target was reached globally. And that due to the setbacks that we all know, COVID-19, decreasing ODA funding, climate change, and conflicts in the world. So globally, 4.5 billion people still lack access to essential health services in the world, and 2 billion people are facing financial hardship due to increasing healthcare costs. And so acceleration is needed on this UHC agenda, which still remains a key priority of WHO and will also remain to be that in the future, especially as international funding for global health is decreasing. So more than ever, the EU is a key partner for WHO, mainly also through this UHC partnership, one of the biggest initiatives that was developed to promote international cooperation on universal health coverage and primary health care, which is now covering over 125 countries and 3 billion people around the world. But the partnership between WHO and the EU also covers the internal dimension, which is the focus of today's discussion. Because indeed, also within the EU, the UHC agenda is not a mission accomplished. Access inequality persists between countries, but also within EU member states. And so even if accessibility is essentially a matter of member states to deal with, the EU influence has been growing over the years, and the instruments for monitoring, coordinating, and supporting national policies in this field have expanded, as we know. Under the European semester, we have seen the Commission issuing country-specific recommendations, inviting member states to strengthen the resilience of their health systems, but also to improve access to healthcare, and supporting this through financial instruments like the Recovery and Resilience Facility, the EU4Health program, and cohesion funds. But effective monitoring and relevant policy guidance requires good data, as well as a good understanding of the various dimensions that determine affordable access. And so this is what we can expect to be discussing today. And this is also where WHO Europe, also through its Barcelona office, is providing valuable input and support. And I think today's discussion is very timely because in these times of uncertainty and geopolitics, priorities are shifting fast, also in the EU. With initiatives like on the EU agenda, like the Critical Medicines Act, the Biotech Act, strategies on medical countermeasures, on stockpiling, it could seem as if the Commission's focus is more turned towards health security, promoting innovation, availability, so to ensure Europe's competitiveness and strategic autonomy. But let us not forget that in the Draghi and the Letta report on completing the European single market and increasing and ensuring Europe's competitiveness, the reduction of disparities in access and quality of healthcare also was mentioned as an important and critical component of Europe's future and its green and digital transition. So it's good to remind this as a discussions on the next multi-annual EU budget. The MFF is going to start soon. It's important that the health dimension and the aspects of affordable access will not be lost in this discussion. The past has taught us that the right to timely access to affordable and high quality healthcare is of critical importance, not only for the resilience of individual people, but also more broadly for economic productivity and social prosperity. So I wish us very good and enlightening discussions today. And I gladly hand over to my colleague Natasha Azzopardo-Muscat.
Thank you, Willy, for that excellent introduction. And also thank you to you and our team here at the Brussels office for having supported the Barcelona team with the organization of this event. And I think it's great that we have come here to be with you in Brussels for all the reasons that Willy has so eloquently outlined. But let me start by saying what is the politically correct thing to start saying, and then to move on to our real agenda. The politically correct statement is to say that today we are convening to mark the end successfully of a project we have carried out in partnership with the support of DG Santé, and which the Barcelona office has provided a huge amount of data, evidence, and information to guide policymakers. But this gives us a false sense of satisfaction because it can lead us with the impression that our work is done. We've collected the data, the evidence. At the start of the project, there were huge gaps in several EU member states when it comes to monitoring of financial protection. Thanks to the work of this project, we have been able to close these gaps. We have been able to raise awareness around financial protection and unmet need at national level in many countries, at European level too. But this is not the time to actually close this project, because as Willy has outlined so clearly, this is the time when member states are actually going to need all the support they can get, the best evidence to ensure that we don't fall into knee-jerk reactions, to ensure that when it comes to the citizens of Europe, of the European Union, one of the richest parts of the globe, we don't leave people behind and we don't leave people exposed. And a number of policy initiatives that will be unfolding will threaten, in fact, the coverage of those people who are already unhappy, either because they are unwell or because they live in rural areas where healthcare access is becoming more and more difficult, or because they are pensioners whose pension is not keeping up with inflation, rising energy costs, and everything else. And therefore, they are more likely to fall into the reality of facing catastrophic expenditure. The good news is, with the work and the modeling done by our excellent team in Barcelona, we can help member states and guide member states to understand the impact a priori of certain decisions, and in times of austerity, to be able to protect those most at risk and to take the least harmful decisions. So this project has enabled us to launch a number of innovative products, such as the UHC Watch, this interactive platform that will allow policy geeks, university academics, but maybe also civil servants who are asked within 2 hours to provide a brief to their minister to be able to really find the data that they need at their fingertips. So thank you very much for allowing us to do this. But we need to go further. And many of you are asking, what is happening in WHO? Where are your priorities going to be? So I'm delighted also on behalf of our regional director, Dr. Hans Kluge, who Willie tells me is actually flying in tonight. So we're doing a team tag here to say that during the first 5 years of his mandate, leaving no one behind was a critical priority. And I think we have continued and continuously continue to put this on the agenda, not just, however, as words, as a normative stance or as a moral imperative, although we shouldn't stop paying attention to norms and moral imperatives, but also because fundamentally as an organization, we believe in making decisions that are informed by science and by evidence. And in this area of work, we have more technical evidence than we have ever had before, but we also have areas where we want to do more, such as in the area of aging and long-term care financing, such as when it comes to financing for innovative technologies. So the work will continue. But you may also hear us talking about WHO having, in the midst of the financial crisis that we are going through, having to go back to the basics. And I'd like to reassure you that it is very clear that the WHO Barcelona Office will continue to be a solid and reliable partner for all of you, because when we talk about going back to the basics, there is nothing more basic than the monitoring of financial protection when, for example, public health services are not meeting the demand and people are shifted then to find their own solutions, as one would expect in low and middle income countries, but this starts happening also in the high income countries in the European Union itself. So this remains at the heart of our agenda. And as we move forward, although of course we are being asked by our member states to help support with preparedness, for example, for health security, which requires us even to go into new areas where we haven't been so active before, such as preparedness for defense, such as the mental health preparedness when you have all of these circumstances happening. We will continue to remain very, very much focused on monitoring financial protection and providing advice and support to member states with the very difficult decisions that they are grappling with in these tough times. Thank you so much for being here, and we look forward to the discussion.
Thank you, Natasha, and thank you, Willie. My name is Charles Normand. I've the privilege of being asked to moderate this session today. I've worked for a long time with the Barcelona office colleagues, and I think I could go as far as saying I've enjoyed working with the colleagues from Barcelona for a long time. The only thing I wanted to be critical of is they put a title there, How Can Europe Sustain Affordable Access to Care? They should have put the title, How Can Europe Sustain and Enhance Access to Affordable Care? But I was always a little bit ahead of them, so I'm sorry about that. What we're going to do is we've got the first session, the first part of this session, John Silas is going to talk a little bit about the scene and the challenges that we face. And then we're going to go on to having another session, which will include a panel where we're discussing some of the issues, looking particularly at particular countries and the experiences in particular countries, so we can try and ground things in that reality. So John Silas is saying, setting the scene, threats to the financial sustainability of health systems in the European Union.
So yes, so I'm going to try and set the scene here by talking a little bit about the outlook for public spending on health. And that is not the right direction. Let's see. There we go. So why start by talking about public spending on health and the outlook going forward? Well, in European countries, and actually globally, countries that spend more of their resources on government spending on healthcare rely less on out-of-pocket spending to finance health. So this figure here, this is looking at the most recently available data for the EU 27 countries. On the horizontal axis, we have government health spending as a share of GDP, and on the vertical axis, out-of-pocket spending on healthcare, the share of out-of-pocket spending that goes to healthcare. And we see that the countries that dedicate more of their resources rely less on out-of-pocket spending. And of course, out-of-pocket spending and affordable access is the topic of this event. But this does raise questions going forward. Will there be budgetary space for health in the coming years? So to try and understand this question, I first decided, as everyone does when they have a question, to ask ChatGPT. And so I asked ChatGPT, can you make me a political cartoon? Do you think that countries will be able to pay for healthcare in the future from government funds? And ChatGPT produced this very sad masked man with a very heavy globe on his back. And so I think it does seem challenging to imagine that countries in Europe will be able to spend significantly more from public funds on health going forward. And of course, there's work from WHO that shows that in recent years, the most recently available data shows that many countries globally have deprioritized health. But I also realized that asking ChatGPT for a political cartoon is not the most systematic way to answer this question. So I thought we'd go back to basics and think about what determines budgetary space for health, or in the literature, oftentimes it's referred to as fiscal space for health. And there are four main mechanisms. The first is economic growth. So this idea, obviously, if economies grow, then countries are able to collect more tax revenues. And even if they prioritize health in the same way in the future as they do now, a bigger pie means more money for health. The second way to increase budgetary space for health could be new earmarked revenue sources, new forms of taxation. A third potential way to increase budgetary space for health is through efficiency gains, so to continue to produce the same or better health outcomes using less resources and use the savings to reallocate somehow for more different purposes. Or to reprioritize the budget, the overall government budget. So to find more space for health, increase the priority in the government budget for health. And so what I wanted to do was ask, okay, well, what do we think for each of these four? Do we think that European countries are going to be able to spend more on health in the coming years? So the first is economic growth. So I didn't turn to ChatGPT. I turned to a new report from the ECB, the European Central Bank, which shows the forecasts. This here shows forecasts from March for real GDP growth and the different components. And so across the EU, the expectation in 2025 is about a little under 1% growth in real growth in GDP, and a little bit higher in 2026 and 2027. Nevertheless, these are revisions downwards since the December forecasts. So real GDP growth in 2025 has been forecasted to be 0.2 percentage points slower, so fairly large decline, mostly driven by declines in exports. And even in future years, there's an expectation of slower economic growth than was expected even in December. So I think somewhat pessimistic. These later years are due more to assumed reductions in investment. But I think if we count on economic growth as a source for more budgetary space for health, maybe not the most reliable source. What about new earmarked revenue sources? So oftentimes in European countries, and the most commonly earmarked revenue source for health is social contributions, which are linked to the labor market, so paid by employers and employees. So is there scope for more social contributions? Well, this figure here shows the share of the working age population in EU countries in this year, 2025, but also forecasted in 2035 and 2045. 2035 is in red, and 2045 is the green bar. And what you can see in virtually all countries, with the exception of Malta, the working age population is expected to shrink. And in Malta, it's because of immigration. But so if we think about social contributions linked to the labor market as a reliable source of additional revenues for health, Probably not, right? The revenue base is expected to shrink, even if you just look at the EU 27 overall, from 58% of the population at working age 20 to 64, over 10 years falling by 2 percentage points and falling another 2 percentage points 10 years after that. So not from shrinking working age populations, probably not a reliable way to generate more revenues. What about health taxes? These are very popular to put taxes or to talk about taxes, at least on alcohol, tobacco, sugar sweetened beverages. Maybe these are a good option for new earmarked revenue sources. However, health taxes are designed to change behaviors. The idea is that people will consume less of these things. So they're also not the most reliable revenue source. And if you look across countries that have them, they don't generate very much money. So I think in terms of the scope for new earmarked revenue sources to generate much more money, I think also this is very unlikely. Efficiency gains, the third one. So we actually did a paper a few years ago on whether efficiency gains lead to more resources for health. We found, generally speaking, that countries that aim to improve their efficiency usually experience budget cuts. So even though efficiency is not the same as cost cutting, it usually ends up that way in practice. But if we think about even going back to the financial crisis, some of the most effective ways that countries achieved efficiency gains was by reducing prices. So maybe the question is, can health systems in Europe reduce the prices they pay for care and keep the volume the same? And I think the answer there is also probably not. So this figure here shows consumer prices going back to 1997 in EU countries. You can see the most recent spike in inflation following the COVID pandemic. But also, again, going to this report from the ECB, upwards revisions to inflation. So expectations that prices in the general economy will rise more quickly. And this makes it very hard, of course, to put downwards pressure on prices in healthcare. And lastly, budget reprioritization. Natasha mentioned this. Countries across Europe are spending more on defense. It's very unlikely that they are going to have much more money for health. Okay, well, what was happening before the pandemic? Has it always been this difficult to raise money for health? So this figure shows high-income countries in the WHO European region, so all EU countries plus a few others, looking back to the financial crisis, and it's looking at government expenditure as a share of GDP, which is in green, so how big is government, versus the priority given to health in the budget, so this is in orange. And what you can see is that following the financial crisis, on average, countries across Europe shrunk the size of their overall government. Not a lot, but from about a little less than 46% of GDP to on average about 42% over around 10 years or so. But during that time, the priority for health increased. Not very much as well, but enough to keep health spending relatively stable. Now, if we fast forward to COVID and we look, okay, well, what happened with public spending during COVID? Well, during COVID, as we all know, there was a lot of additional health spending because of the pandemic. And if we look to see where that money came from, this graph here shows for a number of EU countries how countries compensated, especially for losses in revenues and other sources. So in many countries, people were not able to go to work, social contributions fell, and governments stepped in and by and large increased budget transfers to health insurance funds. They had more direct payments from budgets overall, from ministries of health. So some would argue that health has already had a really, it's had its day, right? It has seen much more priority given to health in recent years. It had much more resources during the pandemic, and maybe its day is done. And I think that's a reasonable concern. It does seem like very unlikely to imagine countries in Europe, at least in the next couple of years, spending considerably more on health. So then this raises this question, and this is really the motivation for the rest of the session. Well, what if countries don't raise enough money for health through public funds? The risk is that countries will, if people continue to use services in the same way that they do now, then the those services will have to be paid through more out-of-pocket payments, either because countries will implement user charges, or they'll raise user charges, or they'll ration in other ways that will lead people to pay to go private directly. Either way, whatever the mechanism is, if there's no additional public funding for health, it's very likely that households will bear the costs of financing healthcare more at the point of use. And this, as we'll talk about, not only causes some people not to use healthcare at all because of the cost of using of the cost that they would experience if they used healthcare, but also causes financial hardship for many households who do end up using services. So the question is, how can we monitor the risk of financial hardship from out-of-pocket payments? And then importantly, how can we identify protective policies? If we assume that there's a chance in many countries that out-of-pocket spending will increase, then we need to make sure that we have the right policies in place so that if there are increases in out-of-pocket spending, the distribution of that out-of-pocket spending does not fall to the most vulnerable households. And with that, I pass on to Tomasz Avedovich, who will tell us about monitoring the risk of financial hardship.
Thank you, John. So my task is now to give you an update on the evidence on financial protection. Today, we have 3 key messages for you. Think differently about health financing. There are long-held misconceptions about how health financing should be done, and we would like to challenge some of them. Second, use evidence on financial protection because now we have them. We did not have them before. They had good excuses for ignoring the evidence. And the third is follow good practices, learn from good practices, and don't fix yourself on how to get the bad practices work better, because they will not. So focusing on an update on the evidence on financial protection, let me tell you why it's an update. We published at the end of 2023 a regional report on financial protection. Can people afford to pay for healthcare in Europe? Covering 40 countries in the European region and all EU countries for the first time ever. And compared to that evidence, which was pre-pandemic data up to 2019, we now have data up to 2023 for some of the countries. And that's what you can find on our UHC Watch platform, an online platform where all the evidence is available, both data and the good practices that we argue for. But of course, for some of you, this may need a definition. What is financial protection? Financial protection is the degree to which people are protected from financial hardship when they use health services. So it's, of course, looking at the experience of those who use health services. Therefore, we need to monitor both unmet need and financial hardship. Gladly, we have unmet need data because the EU, in the EU countries, it's being monitored. And we bring that together with the 2 indicators of financial hardship, which are well-established indicators, but I'm also happy to share with you that after 10 years of work on this, since 2015 when the SDGs were adopted, and by the way, financial protection is one of the indicators of the Sustainable Development Goals, now globally they are going to use the same approach as we have established in the European region, which was different than the original SDG metrics. Back in 2008, in the Tallinn Charter, the Charter said it's unacceptable that people become poor as a result of ill health. But back then, they didn't have data on catastrophic or impoverishing indicators, except for a few countries like Estonia. But now we have that. So what are those indicators? Catastrophic out-of-pocket expenditure is one of the indicators of financial hardship. It means when out-of-pocket expenditure is more than 40% of the household's capacity to pay. And capacity to pay here means the household's budget that is left after meeting basic needs, after spending on food, on housing, on utilities. And that's the difference compared to the original SDG metrics. And the other indicator is the impoverishing expenditure on health, when the household, either before using health services, were above a poverty line, and as a result of spending out of pocket, they drop below the poverty line, or when they were already poor and we, in the health system, are asking them to pay out of pocket for the services they need. So these are the two indicators. Let me give you a very quick overview of the latest evidence, latest data, also including some of those countries for which we have data beyond 2019 up to 2023, like Czechia, Slovenia, which will be featured today. The range of the figures here, starting from less than 1 up to 8% in Bulgaria, shows that actually none of the European Union countries managed to achieve universal health coverage if we consider the original thinking from the Tallinn Charter that no one should become poor as a result of ill health. And what you see on this chart is very striking, is the red part, which is greater than the orange. The red means that the incidence of those households which actually were already poor before using health services, and then they had to pay out of pocket. The other indicator, catastrophic incidence, shows a range from less than 2% in Ireland, Slovenia, Sweden, and we also use here UK data, up to almost 20% in Bulgaria. So quite wide range and quite large numbers, which are hopefully shocking to many of you, but let me give you an even more shocking data, which is when we look at the distribution of the hardship, and that's really what matters in these contexts. The distribution in this chart shows the poorest 20% of the population, and that's for the darker blue bars, and the lighter blue is the overall, what you have seen before. But now what you see here is that in some countries, the poorest 20% of the population faces financial hardship in terms of catastrophic expenditure to the extent that more than half of them, or even more than 60% of the poorest 20% face catastrophic incidents in Bulgaria. And in all countries, actually, it's the poor who suffer the most. So that's actually already a very policy relevant message here. Who do we need to care more about? Where is the gap in terms of providing financial protection? It's the lowest income people. Now then the next question is, what are they spending money on? And we have here the same countries ranked from lowest to highest catastrophic incidents, but we look and zoom into those bar charts and look at what are the services that they are spending money on. Red stands for medicines, blue for dental care, and the orange for medical products. These are the three main service areas which drive financial hardship. Interestingly, if you think about these are services that take place in primary care settings. Medicines, dental care, and medical products. So financial hardship is mainly driven by treatment in primary care settings. That's one of the challenging conceptual thinking that we would like to discuss today. And then again, distribution-wise, if we look at the distribution of services responsible for catastrophic expenditure, only for the poorest 20% of the population, this is the poorest quintile, then what we see is that even in those countries which provide quite good financial protection, the dominant color here is red. So the next question is that, okay, how can we improve financial protection for poor people, and what do we need to focus on? It's really medicines if you want to go for some quick improvements. And going back to this question that John finished on, if it is going to be more and more out-of-pocket expenditure, let me finish these data charts with this one that tells you what is it, the level of out-of-pocket expenditure as a share of total spending that should be alarming to you as a policymaker. It's 15%. If the country can keep the overall spending through out-of-pocket expenditure as a share of total below 15%, then the incidence of catastrophic expenditure is quite low and variation is relatively small. Once it's more than 15%, variation becomes large and the incidence sharply increases. We knew that. That was not rocket science. The lower the out-of-pocket expenditure as a share of total, the more likely that countries provide good financial protection. But now we have the evidence supported by data. The second message of this is that once you're on this side of the chart, you of course would want to have higher public spending on health, so that is pushing you to the left. But also the large variation shows that there is the huge room for policy changes, because these are variations explained by how protective is the coverage policy in a country and how much it is protecting people who, the lowest paid, the lowest income households, and those who have multiple chronic conditions, lots of medicines consumed. So today we would like to give you, we would like to focus on some of the coverage policy issues that we analyzed across all these countries and figured that some bad practices are continued to be followed in many countries. We identified 5 of those that should be avoided. In the regional report, you find them. We will discuss 3 of them today: basing entitlement on payment of social health insurance contributions, failing to cover treatment in primary care settings, medicines, medical products, and dental care, and applying user charges without effective protection mechanisms. But of course, there are those good practices. We listed them in the summary and in the full report as well, an item of 20 good practices, and we will feature some of these good practices today. Let me just briefly run through the 3 avoid messages. The first one, avoid number 1, linking entitlement to payment of social health insurance contributions. This chart shows population coverage across those countries. On the left, those countries which cover the full population, 100% of the population covered. On the right, the countries which do not cover the whole population. The color stands for the basis for entitlement, either residence-based, it's blue, payment of social health insurance contributions, red. One important message, that there are many social health insurance contribution countries, red on the left, therefore they manage to cover everybody. So it's possible, even if historically the idea is that those who don't pay their contributions, they are not entitled to receive healthcare, which is what's happening here on this side. All of those countries that do not cover the whole population are social health insurance contributions. One conceptual message here is that just because the country has a social health insurance system, it doesn't mean that you cannot cover the whole country. And the normative message from WHO is that you should cover and everybody should be entitled to healthcare. The technical justification comes here when we also show the level of catastrophic incidence. And on the left, you see that the countries that cover the full population have a much better chance of getting closer to 0 or very low levels of catastrophic incidence. The median incidence is 3 times higher in the countries which do not cover the full population. So the first message is that everybody should be entitled to receive healthcare, regardless of whether they paid their contribution or not. The second avoid message is failing to cover treatment in primary care settings. That's what we showed already, that the driver of financial hardship, medicines, dental care, medical products, practically all of them are primary care related or services that are happening in primary care coverage settings. Some of these services are simply not covered, dental care and many of the medical products, but even medicines are not fully covered or covered to an extent through user charges that may actually lead to financial hardship to many or unmet need to many. And this is where I bring in the unmet need message for a moment. On this chart, you see one country, I think it's Lithuania actually, the distribution from the poorest to the richest quintile, the composition of services responsible for financial hardship. As you can see, for the poorer, actually for poorer, 60% of the population is really largely medicines that drive financial hardship. The blue is dental care. It's only the richer population group that face financial hardship as a result of using dental care. And the dots show the unmet need for dental care. For poor people, dental care is unmet need because they prioritize buying their medicines. So unmet need has to be part of the monitoring here, and unmet need is a critical issue also at the level of primary healthcare, as we just seen before. And the third avoid message, if you insist for whatever reason, despite the evidence, that user charges need to be used in the country, then applying user charges without effective protection mechanisms will lead to financial hardship. Again, for whom? Usually the lower income people and those with chronic conditions. Countries try to protect primary care visits by not applying user charges. These are countries, number of countries that percentage of countries using user charges in different service settings. What we can see is that outpatient prescribed medicines, dental care, and medical products, there are user charges more frequently in almost all countries for prescribed medicines in all countries. We provide protection for visits, for a diagnosis, but there is no protection for treatment. If medicines are not covered in primary care settings, that's not really insurance. It's not providing good coverage. And that's what we need to focus on. Thinking differently also about what is there in primary care that needs to be covered. The evidence on co-payments is that it's inefficient and they do not address low-value care. And we looked at the protection mechanisms that explain good performance in those countries which have low incidence of catastrophic expenditure. And what we found that the good practices are exemptions for poor people and those who are most exposed to high out-of-pocket expenditure, caps on out-of-pocket expenditure, caps on co-payments, ideally income-related caps, using fixed co-payments instead of percentage co-payments, and in some countries, very few, actually by now only 2, voluntary health insurance covers those. So these are the good practices. On the other side of the chart, the countries which either have bad practices or they ignore the fact that these actually lead to better financial protection. All these data, evidence, good practices are available on UHC Watch with the briefs, the good practice brief that we are going to cover. So the 3 messages that I would like to end with: think differently about how to finance health services, how to finance health insurance. Use the evidence that is finally available. Let's not have an excuse for ignoring them. And follow good practice instead of continuing to insist on making the bad practices work better. Thank you.
Thank you, Tomasz, and thanks to John. I think what we've seen from this is the huge importance of having detailed, very granular information and a very granular understanding of what the current situation is. And I think it's no longer feasible to say, we just don't know what the effects will be, so we'll just play around with these policies without thinking about it. But there are, I think, in all of this discussion, there are 2 things we've got to be worrying about. One is how we can maintain the free at the point of use or nearly free at the point of use element of care, and what we can do to minimize the harm that is being done by other measures that are being taken. This next session, we're going to have 3 country experiences included. Sarah's going to be taking the initiative, first of all, to talk a bit about this and also to put some questions. But can I ask our panelists to come up now? We've got Adam and Anda from Czechia, who's going to be giving us some insights on that. We've got Lynn Altayera from Malta and Nicholas Bouquet from Belgium. So thank you to our panelists. I'm handing over to Sarah. Just to say, those who are online, we are monitoring the questions that you'll come up in the what do you call it? Chat. Sorry, the chat. I was getting confused with ChatGPT. Well, which probably would produce very good questions anyway. But we're monitoring there. We will try and include some of those questions when we come on to the questions from the floor. But initially, we're going to be presenting some further thinking about this and looking at 3 country experiences. So over to you, Sarah.
Good afternoon, everybody. So Tamas has painted quite a bleak picture, I think, of the state of affordable access to healthcare in the European Union, showing that although there are some countries that provide very good access, very good affordable access to healthcare, there are a lot of countries where the incidence of catastrophic and impoverishing spending is quite high. I think John, where are you, John? Oh, here. John has also painted a very gloomy picture of the fiscal outlook for health systems in the coming years. And my quite challenging task is to try and talk through some of the things that countries may be able to do, bearing in mind the fiscal uncertainty, let's say, that the context, understanding the context is difficult. What can countries do in difficult times? I'm going to talk about the 3 coverage policy choices that Tamas said that countries should try and avoid if possible. The linking of entitlement to payment of social health insurance contributions, the failure to consider medicines and medical products and dental care as part of treatment in primary care, and the failure to cover those things adequately in many countries. And then lastly, this idea of applying user charges, but without effective mechanisms to protect people from co-payments. And I'm going to focus on these 3 different titles here. First, cruel and unusual punishment. Second, are medicines actually healthcare? And then third, why are medicines free inside hospitals, but not outside hospitals? So cruel and unusual punishment. Well, this comes from the Bill of Rights in England in the 17th century, and it then morphed its way into the US Constitution, part of the 8th Amendment. And it's also in a different, slightly different format, part of the UN Declaration on Human Rights. And it basically says that it is acceptable to punish people, but the punishment must also be acceptable. It mustn't be cruel, it mustn't be unusual. It should fit the crime in some way. So we're going to have a bit of audience participation, but don't worry, don't panic. It's going to be very, very easy, very simple, not challenging at all. So my first question for you guys here is, if you think of the country that you come from, if you don't pay your taxes, are you still able to access publicly financed healthcare? Yes, okay. So some brave person who said yes. Which country are you talking about? Okay, great. Spain is a good example. So in Spain, if you don't pay your taxes, you can still access publicly financed healthcare. And can you say why that is? Can you say why that is? Okay, so your entitlement, the basis for entitlement to publicly financed healthcare in Spain is based on being a permanent residence in Spain. So if you don't pay your taxes, which are used to finance healthcare, you can still access healthcare. But let me ask the question in a little different way. So if you live in a country with a social health insurance scheme and you don't pay your social health insurance contributions, can you still access social health insurance benefits? No. Can I just ask quickly which countries you're thinking of? Okay. So Spain, anybody else? Just shout out which countries you're thinking of.
Here it's obligatory to have health insurance. So yeah, you have to pay before to get the services later.
Okay. So in Belgium, if you don't pay, you don't get access to social health insurance benefits. Okay, so thank you very much for those answers. So countries that base entitlement, broadly speaking, on residence, don't punish people who don't pay their taxes by denying them access to healthcare. But in countries that have social health insurance schemes, not all, but in many, including in the European Union, if you don't pay your social health insurance contributions, which, let's face it, are actually a form of taxation, right? They are mandatory. You have to pay them. They are essentially a tax, just called something else. In these countries, in many of these countries, if you don't pay your contributions, you are punished by denying you access to healthcare. And I think the simple point that I'm trying to make here is that this is a rather cruel and unusual punishment for non-payment of taxes. So why do I say this? Why is it an unusual and cruel policy choice? Well, first of all, in the context of EU countries, in fact, in the context of countries globally, it's just not consistent with commitments to universal health coverage. And all EU member states have signed up to this through the Sustainable Development Goals, but also through the European Union's, or the European Pillar of Social Rights, Article 16. And it's not consistent with these goals because unless you have the most amazing and efficient and effective tax collection system, this policy will always exclude some people from coverage. Some people will not have access to the full range of healthcare benefits unless your tax system is working amazingly well, perhaps if you're living in Germany. But it implicitly denies access to healthcare for people often in the informal sector. So this is not a policy that affects everybody in the population equally. This is a policy that systematically, disproportionately harms people with lower incomes, people who have informal employment, or people who have precarious employment, stable, uncertain, insecure, low paid. Often these are low paid workers. And then the third reason is because it really undermines the resilience of a health system facing an economic or some other kind of shock, but also households. And we saw this very much in the global financial crisis, 2007, 2008. When you have this policy at the time when people are most likely to need access to healthcare, as the economy is going down, as unemployment is going up, wages are falling, people find it more difficult to pay, people stop paying their contributions. And in Greece, by 2014, around 25% of the population had lost their access to social health insurance benefits because of the crisis. But we also saw it in COVID-19. What we also saw in COVID-19 was some learning from the previous crisis, where countries like Greece, like Slovenia said, okay, we understand that it's very difficult for some self-employed people to pay their contributions, and we're going to give them a waiver from contributions for the duration of the pandemic. But unfortunately, this was a good fix, but it didn't actually address the root cause of the issue, which was this linking of entitlement to payment of contributions. So it doesn't have to be this way. Many countries with social health insurance schemes automatically think that we have to have this link in place. But it's time to think differently about entitlement, about access to healthcare. And I think we can learn a lot from international experience. In the European Union, first of all, we have the example of France, which broke this link between entitlement and payment of contributions in 2000. And we'll talk a bit more about France in the next session. But we also have an example today from Czechia. So Adam Ander from the Ministry of Health in Czechia, I want to ask you, first of all, when you set up your social health insurance scheme in Czechia in the early 1990s, you decided not to have this link between entitlement and payment of contributions. You introduced a different type of system. So I want to ask you, what happens to people in Czechia, first of all, when they don't pay their social health insurance contributions, and why you chose this option?
Okay, well, I think it was a very special time in the beginning of the 90s because the previous period of socialism or communism somehow raised solidarity among the population. And it was somehow unimaginable to introduce the link between payment of contributions and the healthcare. Because before the Velvet Revolution, everybody was used to receive healthcare whenever he wanted. So this is something we maintained even after the revolution. So there is no link, and there was no broad discussion. It was simply taken as it was.
So if you don't pay your social health insurance contributions in Czechia, you still have access to healthcare?
Yes,
Yes.
It's actually the same as if you don't pay taxes. You still receive the services.
Yeah, exactly. Which it's very interesting that you say that it just seemed unimaginable to you to make this link because it would end up denying access to healthcare to some people. And yet Many other countries in Central and Eastern Europe did introduce a social health insurance scheme and did take that step of linking entitlement to payment of contributions. So it's very interesting that Czechia was very different. When you talk to policymakers in those other countries that have this link between entitlement and payment of contributions, they give two arguments for this. One, they often say that it's very unfair that if you don't pay your contributions, you still get access to healthcare, when there are people who do pay their contributions and they get access to healthcare. So there's people present it as a fairness issue. And the other argument that's commonly made is that, well, where's the incentive? If some people don't have to pay their contributions and still get access to healthcare, then why should I pay my contributions? And they argue that maybe this would encourage people to default on payment of contributions. So was this an issue in Czechia at all? Has it been debated or not?
No, not on the political level. There were theoretical discussions about these arguments, but it's not possible to speak about this before the public, because you would lose all your votes. But the first argument, it's not true that the people don't finance the health insurance, because there is, I would say, 60% of the population that is paid by the government. The contributions are paid by the government. So everybody contributes to healthcare, even if they don't pay their own healthcare contribution. So this is for the first argument. And I just lost my
yes, for the incentive, would it encourage other people not to pay their contributions?
Sorry. It's the same as if you don't pay taxes. You start receiving letters asking you to pay. Then if you don't pay, you receive inverse letters, and then the usual tax recovery procedure starts. So there is a punishment, and everybody is motivated to pay. And if you don't pay, then there are penalties.
Okay, that's really great, Adam. Thank you so much. And so people, it isn't unfair, because people still have to pay their contributions eventually. That it's just the punishment for not paying your contributions is the same as punishment for not paying any other kind of tax. It's not denial of access to healthcare. And Adam, you continue to pay your contributions, even though you could still get access even if you didn't, because you don't want to get nasty letters from the debt collection company. So my last question, does this mean, Adam, that everybody in Czechia is actually covered and does have access to social health insurance benefits?
If you give me this simple question, then my simple answer is yes.
Okay.
There are, of course, some groups that are not insured, not covered, but these are mainly undocumented foreigners, third country nationals, which are difficult to trace. You even don't know if they are really in the country, so they are not covered. But otherwise, everybody who has permanent residence in Czechia, EU residents who have habitual residence in Czechia, employed persons, self-employed, asylum seekers, temporary protection holders, the scope is quite broad, and then you only have minor groups that are not covered.
Okay, great. Thank you so much, Adam. So let me just, Charles, do you want to say something?
Well, I was just going to say, I mean, I think this is a really interesting story, because, I mean, is anyone here in a country where your children can't go to school if you're a tax voider or anything like that? Anyone say, they put up the gates at the school are closed and say, your father or mother didn't pay their income tax, you're out. And yet somehow it became respectable to think that there was a reasonable linkage to be put there. And I think when you step back and say, does this make any sense to me at all? And is the punishment of a relevant size? And again, if you're denying someone who has very serious needs, the tax is enormous. If you're denying someone who's got almost no needs, the tax is nothing. So again, the punishment doesn't fit the crime at all in this case. And I think that's something that we should be thinking through. In any case, people, excuse me, we know that people don't pay their taxes and charges for all sorts of reasons. In Ireland, where I live now, there was the old joke that paying your taxes never caught on. It never became fashionable to do that, because that would mean you somehow approved of government. And the relationship between government and the population is really what determines whether people will or will not pay their taxes. I'm glad to say I pay all of mine, and I almost queue up and say, could I pay a little extra because I have more income than I need? But I think getting away from this linkage just makes so much sense. Okay, Sarah, you're
Yeah.
things to say.
No, thank you, Charles. I'm very happy to hear that you're a lawful taxpayer in Ireland. And I think I just want to end on this, for this segment, end on this, that when we think about non-payment of contributions or taxes, this is really a problem of tax enforcement. It's a problem for the tax agency. It's not something that the health system should be worrying about. And there's just no evidence internationally that breaking this link is unfair, because people are still having to pay their contributions. Ultimately, they still face punishment. It's just a punishment that is more fitting to the crime. So the second segment is this question here: are medicines actually healthcare? And I have a question for you. So how many of you here think that medicines are healthcare, count as healthcare? I do. Most people here, right? Nicholas, good. Natasha? Yeah, everybody. Anybody think that medicines don't count as healthcare? Okay, so I think we have a pretty strong consensus on this here. And the reason I asked this quite facetious question is because, and I will talk about my country here, the United Kingdom. Here you see the Prime Minister and the Minister of Health talking about the future of the NHS. And they say that for decades, the NHS has served us very well, with the enduring principle that everyone should get healthcare that is free at the point of use. So what they are implying is that the NHS is free for everybody, except that if you are in England, not in Scotland or Northern Ireland or Wales, but if you are in England and you're using the NHS, you have to pay for your outpatient medicines. You have to pay at the point of use. It's quite it's £10, more or less £10 per prescription item. You also have to pay for NHS dental care. So it's puzzling that the politicians will say, and not just the politicians, everybody has this feeling in the UK that the NHS is free at the point of use, but not when it comes to medicines or dental care. And just in case any of you are thinking, well, this kind of crazy thinking is the sort of thing that the British like to do. It's one of their crazy, more crazy decisions. I think they have some other quite interesting decisions too. In case you're thinking that this is a UK thing, I want to show you that it's not. So this is the slide that Chamash showed, which shows you the percentage of countries applying user charges to different types of healthcare. And many countries will say that they have primary care that is free at the point of use, because primary care visits are free. And so about 50% of the countries have no user charges for primary care. But in many of these countries, you have to pay for medical products, for dental care, for outpatient prescribed medicine. So things that we would think of as common treatment in primary care settings. So if primary care treatment is not free, then either primary care is not actually free, or medicines, dental care, medical products are not really primary care. So which is it? It can't be both at the same time. Okay, I'm presenting this in a very provocative way. And I want to turn to Lynn now to ask her about the experience of Malta with this. And the reason I'm asking Lynn is not because she is from Malta, but because she is the editor of a new financial protection report on Malta, which is coming out in the next 2 weeks. And I should say that we also have a Czech report on financial protection coming out in a couple of weeks, and Adam kindly reviewed that for us. So Lynn, turning to Malta, can you tell us a little bit about how what we're talking about here relates to the Maltese experience?
Thank you, Sarah. So let me just start by saying that in Malta, all publicly financed healthcare is free at the point of use. So there are no co-payments for all types of healthcare. But when we talk about outpatient prescribed medicines, they are only covered for two groups of people: people with chronic conditions or people with low incomes. And this is through something that's called the yellow and the pink card scheme. So basically, if you have an eligible chronic condition, you are entitled to a yellow card, which grants you access to free outpatient prescribed medicines to treat your condition from the formulary. And if you have low income, you are entitled to a pink card, which grants you access to also some medicines from the formulary. However, everyone else who's not eligible to either a yellow or pink card must pay out of pocket fully for outpatient prescribed medicines. And now it might seem that Malta offers a lot of good practice for other countries, being not having any user charges and protecting those who are most vulnerable, like people with chronic conditions and people with low incomes. But when we look at the data and what we see in the report is that this actually is not enough, because outpatient medicines are the main driver of catastrophic health spending, especially for the poorest quintile, and it's higher than other countries in the region. And when we see that, we realize that actually the protection mechanisms that are in place, being the yellow and pink cards, are not sufficient or are not designed in a well-protective manner for those who are most vulnerable. So I'll just give an example, for example, about the yellow card. The yellow card only grants you access to medicines from the formulary, and the formulary might not be updated or following the latest available treatments. So actually people might bypass the medicine that's available for free on the yellow card and go and spend out of pocket on medicines. And this puts a lot of vulnerable people, exposing them to financial hardship, especially, for example, people with low incomes that do not qualify for the pink card, but also who have children, for example, or even pensioners. So all of these groups are vulnerable and are exposed to these high out-of-pocket payments for medicine. And it goes back to the idea that Sarah was just illustrating, that medicines are definitely must be considered part of healthcare, because even if we do actually cover all the other types of healthcare, it's clearly showing that it's not enough in the Malta case. I don't know, Natasha, if you want to compliment her as the Maltese person. Also wearing the Maltese flag colors.
Now it is. Thank you, Lynn, for that very eloquent description of the system. But I think today Sarah has inspired me with her slide of the British NHS. You were challenging me yesterday, asking, how is it that medicines are so separate in a health system that is otherwise totally free at the point of use? And I think Sarah has given the answer as a former British colony, and the system having evolved 80 years ago, very much based on those principles. I think sometimes it takes time to take a step back and say, are we really still fit for purpose, particularly where we have a large number now of older persons? But the other question that I think needs to be on the agenda is, being a small market, how do prices compare? And there is more work and digging to be done over there from a catastrophic out-of-pocket payment expenditure. And the third element is also, you touched on the important issue of innovation and the formulary perhaps not keeping pace. But the fact also that sometimes it's important to dig into what are people actually spending that money on. And as you know well, in Malta, the primary care and outpatient system is also very much to an appreciable degree carried out in the private sector. So I think the lesson is always that one needs to really dig deep to understand what is driving this. Of course, there's always room for improvement, and it's an issue that I did push for when I was Chief Medical Officer, both in terms of formulary expansion, as well as trying to keep abreast with the changing nature of the population. So I think those would be my two key messages. But it was very nice hearing your description. Thank you.
I think this is a very useful bit of discussion, because the Maltese example, I think, has one particularly nice feature to it, in that it brings arbitrary things into the equation. And I can give you a nice example from Ireland, where you've really got to choose your disease very carefully. If you can make sure you have a cancer, you're in good shape, because the cancer drugs are pretty much all covered. But if you're stupid enough to have heart disease, and unfortunately most Irish people are stupid enough to have heart disease, it's one of the worst areas in Europe for heart disease, then your coverage is much less. Now, I mean, I can understand that. Obviously, people who choose cancer are obviously wiser and more thoughtful and more more deserving of treatment. Would everyone agree here? Really choose cancer, it's the great one to have. Or is it just that people are scared with the notion of cancer and politicians are willing to scrape up some extra funds to cover the cancer costs? I give that example because I think every time you start trying to do something complicated, and you've got two colors of cards, in Ireland we have two colors of cards too, so we're running equal. It obviously shows the English, I didn't say British, I said the English influence in here is very important. But as soon as you start trying to do this, you make a new set of anomalies. And then you have a new set of things to offset the new set of anomalies, then you get a new set of anomalies. And all of these mechanisms, I think, make no sense. And why somehow we think you tell someone in great detail what they need and then don't give it to them. It doesn't seem to make any sense at all. And it seems to me that the only explanations are historical. And that is to do with some of the institutional arrangements that led to the way that drugs were distributed. Also, of course, drugs used to be relatively cheap. And when drugs were relatively cheap, people didn't mind so much and it wasn't so worth organizing it. Now we know a lot of drugs are not at all cheap and nevertheless may be hugely effective. And I think it just makes no sense at all. We also had some discussion on oral health. And my mother died 3 months earlier than she would have done because of poor oral health. Now, I say that, I mean, I may be wrong. It may have been 2 months. My point is simply, we somehow think that oral health is not at the same level as other areas. But in fact, the interaction between oral health and general health is enormous. Also, has anyone here had toothache and said, I don't really mind about that, it was just fine? Who here, last time they had toothache, said, that was just great. I was okay with that. I took a few bits of aspirin and it all went away. Or do you think toothache is actually kind of a problem? And if we look at the patterns of oral health that come out, one of my favorite statistics is the largest number of unfit for service Irish soldiers are people with tooth decay. The most days are lost from tooth decay than any other single illness. Of course, people who join the army tend to come from lower socioeconomic groups who are more put off access to dental care than other people. I just give these examples because I think when we sit down and say, does it make any sense? I'd like to see a show of hands here say, yes, it makes sense. Can I see this forest of hands going up? Yes, it makes sense. Oh yes, it makes sense to Sarah. Okay, I'll let
That's all that matters.
explain why it makes sense.
So I love Natasha's idea of blaming things on the English, just in the same, but in the same way that the English can no longer blame everything on the EU. I think that it's time to move on from this thing. And I think it doesn't have to be this way. It's time to think differently. We slightly picked on Malta here, but I'm happy to say that Malta was the only outlier in terms of not covering medicines for the whole population. But as Charles has said, dental care, many other EU countries can feel ashamed at the lack of coverage of dental care, particularly for adults. And that's something that needs attention. And the final point here, bringing it back to John's very gloomy prognosis for the economy in Europe, is that making treatment in primary care affordable for everybody, I think really does probably save the health system money in the longer term. Because if you don't provide access to good quality medicines, dental care, medical products in primary care settings, people will end up using emergency services, which are much more resource intensive. All their diseases and their conditions will get worse, and they'll end up in hospital again, more expensive for the health system, more unpleasant for everybody. So moving on to the third and final segment before we break for coffee. The third question, why is it that medicines are free inside but not outside hospitals? So my question for you, the audience participation, so how many of you have had to pay for medicine when you've been in hospital? Explicitly having to pay for medicine while you've been an inpatient in a hospital. Anybody here? Yes? Which country? Oh, Bulgaria. Oh, interesting. Okay. Anybody else with this experience? Yes? In Belgium, okay, good answer. Both of them interesting answers. So how many here, so 2 people here had to pay for medicines in hospital. How many here have had to pay for medicine on an outpatient basis in the community, in a community pharmacy? Like most people. Those of you not putting your hands up are either very healthy or doctors or... So I think most of us have had this experience where medicines are free if you are an inpatient, you're in hospital, but the minute you step outside the hospital, somehow those medicines are something that you have to pay for out of pocket through a copayment or the entire cost. And I want to just show you this slide here, which shows you the number of EU countries with copayments for different types of healthcare. And I'm just focused on these 4 types for now. And you can see that only 2 out of 27 EU countries make people pay for inpatient medicines explicitly. And actually, Bulgaria was not one of those 2. So maybe there was something else going on in Bulgaria that meant that you had to pay for your medicines, maybe an informal payment, or maybe the medicines just weren't available as an inpatient. But only 2 countries, Belgium is one of them, and the Netherlands is the other. But I think by the time you get to hospital in the Netherlands, the deductible has been maxed out and you probably don't have to pay for medicine. So only 2 countries make people pay for medicines in hospital. But 26 out of 27 countries make people pay for outpatient medicines. And the only country that doesn't here is Malta, where it's free if you have a chronic condition or if you have a very low income. So we're all in good company here. So this is just the case across Europe, that medicines are free in hospital, but not outside hospital. And I think it's just important for us to think about why that is the case. Why is it that these 2 different locations are treated so differently in terms of out-of-pocket payments for people? And the last thing I just want you to notice on this slide is that when it comes to outpatient medicines, the type of copayment is very telling here. So many countries have percentage copayments for outpatient medicines and don't have them for other types, or don't have them so much for other types of healthcare. So the third coverage policy choice to avoid is to avoid applying user charges without effective mechanisms to protect people from copayments. So this chart here shows you from some work that John has done with us, the share of households, the predicted probability of catastrophic health spending in the 27 EU member states under 2 different scenarios here. In the first one, 20% of households are predicted to be at risk of incurring catastrophic health spending. And in the second scenario, only 2% of households. So what explains the difference between these 2 scenarios? So in the first case, these countries have copayments, but there are no protection from these copayments. And we're focusing here on copayments for medicines. The rest of the session is focusing on medicines. No protection from copayments for medicines. Whereas in the second scenario, you may have copayments for medicines, but they are low fixed copayments. So it's a flat rate. You know, it's €1 per medicine or €5 per medicine. It's not a percentage of the cost. And there are exemptions from these copayments. And there's a cap on copayments so that everybody knows they don't have to pay more than a certain amount in a year. So you can see from this that the design of copayments, not just whether you have copayments or not that matters, but how you design them that makes a huge difference, a significant difference to the risk of financial hardship for countries in EU countries. But unfortunately, many countries just don't pay enough attention to this issue. So it doesn't have to be this way. Time to think differently. Tamas has already said, and I think Charles has elaborated on this too, that copayments are really inefficient. Often the reason for copayments is that policymakers think that there is inappropriate use of healthcare, and they think that copayments are a good instrument for this. But we know from a vast literature that this is not the case. There may be problems with inappropriate use of healthcare, but this is something that you address on the supply side, looking at what healthcare providers are doing, not on the demand side. It's just not a good instrument for addressing this particular issue. If you do have copayments, they should be very simple, very transparent, with multiple mechanisms to protect people. And those protection mechanisms should be automatic, so nobody has to apply for it. It just happens to you. You don't even have to be aware of it. And it should be linked to income in some way. And this brings us back to the fiscal constraints that countries face. If a protection mechanism is linked to income, so it's more protective for people with lower incomes, that acts as an automatic stabilizer when you have an economic shock of some kind. It's a counter-cyclical policy that runs against the economic cycle. So as the unemployment goes up or wages are going down, people are losing their jobs, becoming poorer, the automatic stabilizer kicks in and you're automatically protecting the people who most need protection at that moment in time. And if you link it to income, it also softens the budget impact because you're really focusing the limited resources you have on the people who need most protection. So the rest of this, I'm just going to illustrate these points with some country examples, and then I'm going to ask some questions to Nicholas, who's been waiting very patiently for his turn over there. So we want to avoid co-payments that are complicated, that are designed basically to protect the health budget, to protect the health insurance fund or the health insurance scheme. And often, as so many of these challenging practices that we've talked about today are a hangover from the past, something that happens because they either inherited it from some other country or it's just how things have always been done. So 3 types of co-payments that are really challenging for health systems for affordable access to healthcare. Percentage co-payments, where you pay a share of the price instead of a flat fixed rate. They shift risk onto people who have more conditions and need more medicines, but also onto people who may have more expensive conditions requiring more expensive treatment. So they're unfair and they expose people to inefficiencies in the health system. If your doctor doesn't prescribe you a generic and your pharmacist doesn't dispense a generic, then you will pay for that inefficiency in higher out-of-pocket payments. The other complex type of co-payment is what we call the avoidable co-payments that come when you have an internal reference pricing scheme. And there's a reference price, and the user pays the difference between the reference price and the price actually charged in the pharmacy. And many countries in the EU have this kind of scheme in place. But these also can have a damaging impact on people, shifting risk onto households unless they are really clearly and robustly supported by a strong generic prescribing policy, by strong generic substitution policies in pharmacies, and also by saying if the medicine is not available at the reference price in the pharmacy, then of course we're not going to make you pay for a higher price medicine, because that's a system failure to make sure that medicines are available to you. And all of this is going to be described in a new brief on internal reference pricing that is coming out very soon. And just the last non-transparent, complex type of co-payment is balance billing, which is like internal reference pricing where there's a price, but doctors can charge people more than the reimbursement price set by the health insurance fund. And again, it shifts risk onto people. It's often very confusing because people don't know in advance what the doctor's price or the hospital's price may be. And often it skews resources away from healthcare need because it would be people who can afford the extra price who may benefit then more from public resources as well. So if you have co-payments, it's best to try and keep them low, to have fixed co-payments. These are much more transparent, much easier for people to understand, and therefore much less harmful in terms of financial hardship and unmet need for healthcare. And just a very quick illustration, in Finland, a few years ago, they changed the co-payment type for diabetes medicines from quite a low fixed co-payment of €4.50 to a percentage co-payment of 35%. And this sounds like it could be quite a modest change, but it had quite significant impacts on people in Finland. It increased people's reported financial difficulty in accessing these medicines, people with diabetes. It increased the use of social assistance. It reduced the way that people's perceptions of the fairness of the health system and satisfaction with diabetes care really went down among people with diabetes. And it really didn't address the root cause of the problem that was causing the issue for the government in the first place, which was the rising cost of treating people with diabetes. And I think the simple message, 2 messages, one is that the type of user charge matters. It really has an impact on people. So a low fixed co-payment is much more protective than a percentage co-payment. And that if you really want to address the issue of the rising cost of medicines and rising use, you need to focus on what providers are doing. And in Finland, they knew that they were going for a quick fix. They knew that the problem really was on the side of the providers, but they didn't feel that they had the time or the political the capacity to actually address this issue. And so they went for what seemed like a quick fix, but it had detrimental consequences for people. And you can read about it in our new brief, which is in the back of the room. So if you have co-payments, keep them very simple, very low, very fixed, but also protect people. And Tamas has showed you this slide. It just shows you that when you have multiple protection mechanisms, catastrophic health spending is going to be much lower. And this means two things in particular. One, exempting people with low incomes or people with multiple chronic conditions from co-payments. There's just no economic sense in making these groups of people pay for co-payments when it leads to detrimental consequences for their health and for financial protection. And also to have caps that protect everybody so that there's some financial certainty for the whole population. But linking these caps to income, which means that you are being much more targeted, much more efficient with your protection and softening the impact on the budget as well. So trying to focus your protection on the people who need it most. And just a very quick example from Austria, again, in a new brief that we have, which is at the back of the room. Austria's income-based cap on co-payments, it's set at 2% of household income. It's for co-payments for outpatient medicines. And it really makes a difference. Before they introduced the cap, among poor households with catastrophic spending, they were spending a lot of this catastrophic spending on outpatient medicines. And in 2009, after the cap was introduced, the share spent on medicines really went down among the poorest fifth of the population. So making a big difference there. And then the last example, before we turn to Nicholas from Estonia, if you have protection mechanisms, it's not enough just to have them. They need to be automatic. And this is where digital tools, people love the idea of using digital tools in health. This is where they can really play a part in making protection automatic. And again, we have an example from Estonia in the good practice briefs at the back. Estonia did two things. It increased the number of people eligible for a particular protection, say for reduced co-payments after you'd paid a certain amount of money on co-payments out of pocket. But it also made it automatic in the pharmacy. So it was the pharmacy IT system automatically just reduced your co-payments when you reach this threshold. And the numbers are very clear that the number of people benefiting went from about 40% to 100%, overnight, 100%. Everybody is benefiting who should be benefiting. And the other numbers also improved. The people with prescription benefiting from lower co-payments from less than 1% to over 15%. And the cap, the number of people spending a large amount of money on medicines per year, also massively down from 24,000 in Estonia, which remember is has a very small population, about 1 point something million, down to 1,000. So having a real impact on financial protection there. So I'm going to stop and turn to Nicholas. Nicholas, thank you for waiting patiently for this moment. You're from Belgium. We're very happy to have a representative from Belgium here, not representing the country. Nicholas works for the Belgian Healthcare Knowledge Center, and you were also the lead author of the report on financial protection in Belgium. We love the Belgian example, you know, for various reasons. But one thing I would say is that we could look at the Belgian example, the use of co-payments and out-of-pocket payments in Belgium, as an example of worst practice. That's a rather provocative statement for you to come back at me at. So why would we describe this as worst practice?
Well, I was going to say worst sounds a bit harsh, but I do understand what you are referring to. So in Belgium, out-of-pocket payments have consistently made up about 18 to 20% of health spending, which is above the 15% that Tamas has put forward as a threshold. And it's well above what we see in our neighboring countries, the Netherlands, France, where the share is about 9 to 11%. And so one of the main reasons is that co-payments are everywhere in Belgium. So they apply to nearly all services, so outpatient specialist care, but also GP care, emergency care. It all has a price. And so these are services, as you saw, that are exempt in quite a few other European countries. Also, the co-payments are complex, so they vary by service. They vary if you have a referral letter of your GP, if you have a medical record. In some cases, like prescribed outpatient medicines, they're still percentage-based, so they're quite complex. And this, in combination with the several financial protection measures that we have, aimed to reduce the impact of these very co-payments, make the system hard to navigate for some people. So there's no simple general exemption from co-payments in Belgium for low-income people or for chronic care users. Everybody is expected to contribute. And while co-payments are often small, so let's say €4 for a GP consultation, they cannot add up and become a barrier. And then there's a way co-payments are handled is also important. So in outpatient care, we have a system, that a retrospective reimbursement. So that means that many patients still have to pay the full price up front and then are reimbursed later by the health insurance fund, which can be a burden for people on tight budgets. And then we also, so this is different in inpatient care and in outpatient medicines where you have third-party payment. But so it's still in outpatient care that we have this retrospective reimbursement. Then there's balance billing, which is the last point that I want to bring up here. Balance billing is particularly common in inpatient care, in outpatient specialist care and dental care. And just to give you an idea, about 70% of out-of-pocket payments in hospital care is balance billing. 3 in 4 dental consultations are with a dentist who charges balance billing. So this is particularly problematic because balance billing is not protected by the main financial protection mechanisms in the health insurance fund. So this is a growing concern for affordable access to care. And while we see that co-payments, they're decreasing as a share of health spending over time, balance billing is increasing as a share.
We might say this as an example of worst practice because it's so complicated. There are so many types of different co-payments that are applied to all sorts of healthcare. But we also like to think of Belgium as an example of good practice when it comes to co-payments. So Nicholas, can you tell us a bit about that?
So yeah, that's also true. We have a system that might not be perfect, but we have also strong financial protection mechanisms in place to protect or to limit the financial burden on low-income households and on people with chronic care needs. And I will highlight some of them because there are so many that I cannot discuss them all. But so low-income people, they qualify for what we call reduced co-payments, and about 20% of the population is entitled. And for these patients, so GP consultations, the co-payment for GP consultation drops from €4 to €1. And they also benefit from the mandatory application of third-party payment in GP care. And for children in entitled households, they are, since 2023, exempt from co-payments for GP care and outpatient specialist care. So that's one of the protection mechanisms, which is partly automated. And then you have a second one, which is the income, so the cap on co-payments, income-based cap on co-payments per household. And it's described in the policy brief that Sarah has already mentioned. There are some major strengths to the Belgian system. So first, it applies to nearly all co-payments, so including also for medicines, for example, but not on balance billing. It applies to the whole population. It is so the caps are differentiated by income. So the lowest rate is €260, and it goes up to €2,100 more or less. And it's fully automated. So based on taxable income and on your care use, the government knows when to apply and which cap to apply. It's been monitored and strengthened over time. So the lowest cap was introduced in 2022 to better protect the lowest income households. And in 2023, for example, the caps were not indexed to better help households cope with the cost of living crisis. There are some other positive trends as well. I will be brief. So you have, for example, fixed co-payments for GP care, specialist care, which have not been indexed for over a decade, so which is a good thing. We see that the share of practitioners that apply retrospective reimbursement is decreasing. So more practitioners in outpatient care are applying the third-party payment. which is also a good thing. And for balance billing, we also see some positive trends, some prohibitions, for example, recently for medical imaging during office hours, for people entitled to reduced co-payments based on a means-tested social allowance. It's no longer allowed to charge balance billing in outpatient care for these patients. So these are real important steps forward.
Very good things that Belgium has been doing, but are there still some gaps that need to be filled, Nicholas, or some things that can be improved?
Well, yeah, so you already discussed that automatic entitlement is very important. So for example, for the entitlement to reduce co-payments, so part of the population has an automatic entitlement. If you have a means-tested social allowance, then you're automatically entitled to reduced co-payments. But people with low incomes and without this means-tested social allowance, they need to apply. They need to come forward, and many don't. So there's a non-take-up issue here. And we see that 1 in 3 households in poverty misses out on this protection. So it seems a logical next step to expand automatic entitlement. And this is also what's happening. So we see for the, let's say, easier profiles, single person households, they have recently put forward automatic checks on their income and their entitlement. So that's a good step forward again.
Thank you so much, Nicholas. I think what's interesting is that many of you here in Belgium probably are users of the health system, and maybe you don't experience some of the issues that Nicholas has been talking about because you have voluntary health insurance that covers all of these things for you. But I think if you don't have voluntary health insurance covering all of these different elements, then it's a very different story. But we like the Belgian example because even though it is very complex and it is challenging, they have been trying to move forward and make progress. And I think this is the most that we can ask of countries, that you actually understand where the challenges are and you take action to address those that you can. I think the moral of the story from Belgium is that for things like balance billing mainly the retrospective reimbursement, obviously retrospective reimbursement is not something anybody would want to introduce, but balance billing is something that many countries do think, well, actually, this is a way of getting more money into the health system. Don't do it, because once you have it, it's very difficult to get rid of it. And I think this has been part of the Belgian story also. So thank you, Nicholas. I'm just going to wrap up, Charles, and then I'll hand back to you to close this session. It is possible for countries to make progress when countries are willing to think differently about some things and change the way they do things. So the first of all is just let the tax agency deal with non-payment of taxes, contributions. This is not something that the health system should worry about. Improve coverage of treatment in primary care. So this means making sure that there is good coverage of medicines, especially, but also dental care and medical products. And then if you have co-payments, keeping them low, keeping them as simple as possible, and making sure that you have automatic protections in place and that you focus your protections very much on people with low incomes. It's always surprising to me how many countries do actually have exemptions from co-payments. So countries understand the harm that co-payments can do, but in many countries, those exemptions are not explicitly targeting people with low incomes. And the final takeaway, which comes back to John's gloomy presentation, was that these policy choices are choices that will improve efficiency in the health system, because you will get much more appropriate patterns of use through the health system. If people are covered, people have access to these things, and people don't face financial barriers to access or financial hardship. They're also counter-cyclical, so providing automatic stabilizers, protecting people when the economy is not doing well. And I think that's something that is important for the health system to be able to do. And then it strengthens health systems' resilience to shocks, but also the resilience of households. And this is something that ministries of finance can sign up to as well. So thank you very much for listening to me. Thank you very much to our panelists, Nicholas, Lean, and Adam. And I hand back to you, Charles.
Thank you, Sarah, and thanks to the panelists for this. We have a dilemma now. There are two competing human rights: the right to ask questions and the right to coffee. And I think what I would say might be the compromise here is the right to ask 1 or 2 very quick questions or comments if relevant, or if people would prefer to wait, we can include questions in the second session that refer to some of the issues here, because all the issues are connected. So can I see a Is there anyone who's got such a desperate, yes. I didn't finish the sentence, but it must be true.
Second, please.
And we'll all know about it in a moment when you're allowed to speak.
Great. So, Natalia Haraszkiewicz-Birkemeyer, I'm a scientific expert for the European Commission. I have one remark, in fact, because today we are talking a lot about universal healthcare coverage, right? And how certain aspects are distributed across member states, across different countries. But in fact, I think that we should look at healthcare systems more in a more holistic way. Because, for example, what is the percentage spent per country per certain categories of healthcare systems? For example, what is the percentage of GDP which is spent for preventive care or for long-term care? And of course, this discussion is not for today, but I would like already to address these aspects. Thank you.
And I think that what you're raising are obviously hugely important questions. The problem with the question of how much you spend on prevention is most of what we do is when we failed to prevent. Because that's one of the dilemmas. If only you could say to someone, if only you had taken the preventive care 27 years ago, we wouldn't be in this mess now. But to a large extent, the chronic disease crisis has come from that. But you're absolutely right. We should be looking at reorienting. And also, I think it is very important to look at the boundary between health and long-term care. I mean, I have often given the example, but when my mother was sick, a bath was free, you know, a supported bath was free if it was needed for medical reasons, but we had to pay if it was for social reasons. So luckily our doctor said it was a medical necessity. I thought it was a social necessity as well. But I mean, you get these nonsenses in that barrier there. Anyway, I think the coffee side has won, but anyone who is very keen to ask a question on what we've been covering here can speak to me, and I'll give them priority when we have the question and answer session later. Okay, thanks for returning. We're going to move on in the second session to cover something I remember once being told, if you can't measure something, you can't improve it. And we can now measure a lot of these things, so we can begin to think about how we improve them. And one of the things that I've been most impressed with about the program of work at the Barcelona office has been the way in which not only have we got the evidence, but we're now getting the evidence in formats that make it easy to use. And that's a critical part of the whole process of giving people the tools that they need to try to make better decisions and better choices. So we're going to move on now to having a little bit of a look at the UHC watch. I think Lynn is going to give us a few minutes looking at tracking progress on affordable access to healthcare in Europe and Central Asia. So over to you for the moment then, Lynn.
Thank you, Charles. Okay, what is UHC Watch? So you've heard this word today a million times, but you still did not get a chance to look at the website. So what I'm going to do today is I'm going to take you through the website, help you understand how we collect the evidence and how you can find it. So I'll start by introducing this new digital platform of ours. Then we're going to watch a very short video on UHC Watch. Then I will explain to you how you could actually access evidence on financial protection. And lastly, I will end with the European Financial Protection Network. So what is UHC Watch? It is basically our new website that we've created to try and disseminate our evidence on financial protection and increase knowledge translation. What is special about this website? First of all, it is not AI generated. I feel like we've talked about ChatGPT today enough. So I need to dissociate from that because it is not AI. Basically, we've created this website as a sort of a one-stop shop for evidence on affordable access to healthcare, whether you're looking for evidence at the country level or evidence at the comparative level. We have this in all of Europe and Central Asia. What is also special about this website is that it's open access, dynamic, and you can customize your searches depending on what you are looking for. And I'll show you exactly how you can do that. And the last thing is that it really has a wealth of information available over time. In most countries, actually, you will find that we have policy changes that have been recorded over the last 20 years on the website. So I think here we go to the video.
As we work towards universal health coverage, or UHC, we need to ensure that healthcare is accessible and affordable so that everyone is protected from financial storms. Affordable access to healthcare is known as financial protection. It is not only critical for UHC, it is a sustainable development goal. Countries across Europe and Central Asia have made good progress towards UHC, but many people still experience gaps in coverage. This means they face barriers to access or have to pay out of pocket for healthcare, sometimes at the expense of other basic needs. In this way, out-of-pocket payments can push people into poverty. We need to find ways to reduce these payments, but we can't do that without the right information on where and why things are going wrong. We also need to know what to change to make things better. This is why WHO Europe has created UHC Watch, an online platform with data and analysis on unmet need, financial hardship, health spending, and coverage policy in countries across Europe and Central Asia. Designed for policymakers and advisors, academics, journalists, and civil society advocacy groups, UHC Watch makes it easy to find the evidence, resources, and good practice recommendations you need. You can visit the country profiles for a snapshot of who experiences unmet need and financial hardship, and the health services and policies that are responsible. You can use the indicator and policy explorers to get a better understanding of the current situation and to monitor trends over time. You can generate your own analysis, comparing indicators and policies across countries and exporting data and graphics. UHC Watch has the evidence and analysis we need to move us closer to universal health coverage. UHC Watch, tracking progress on affordable access to healthcare in Europe and Central Asia.
Okay, that's great. So I think this is a very comprehensive video showing you all the pages across the website. But what we're going to do now is I'm going to help you look for it. Basically, as you've seen in the video, the people who are meant to be using UHC Watch are policymakers, advisors, journalists, academics, you guys in the room. So we really count on you to really disseminate the use of this website amongst your networks. Now, you've already seen from today's presentations that when we talk about financial protection or affordable access to healthcare, we talk about 4 different bricks of evidence, be it health spending, financial hardship, unmet need, and coverage policy. And what this website does is that it really combines the evidence that you need across all of these 4 dimensions. So if you log into UHC Watch, the first thing that you will see is this homepage, which is the dashboard. You see that there's a map. Obviously, you can zoom in and zoom out when you're online. And there are pins for the countries going from weaker to stronger financial protection. Now, if you look at the menu up top, you see that you have different options. We're going to start by clicking on the countries or areas. I picked Spain, not because it was mentioned today, but we came from Barcelona. So you see here that the first thing you see on the country page is actually the CATA scatter, showing you the catastrophic health spending with out-of-pocket payments as a % of current health spending. And then you see here a dashboard on the left with the latest evidence on both financial hardship, but also unmet need, with a link to the most recent financial protection report. Now, if you scroll down on the same page, you will get to a menu. So this menu is going to be on your left, and you can really choose what evidence that you want to be looking at. So here I chose who experiences financial hardship. What you get on the right-hand side is two graphs. The first one on top is relative to Spain, and you see that the poorest quintile is actually experiencing the most catastrophic health spending. And then the graph that's under that one is actually the international comparison. So whatever evidence that you choose to look at, you get the picture of the country, but also an international comparison. And as you can see, there are other options in the menu, be it on unmet need or on health spending. But here I've chosen to look at coverage policy, or the story behind the numbers. So here we add what are the main gaps in publicly financed coverage. We cover it amongst population coverage, service coverage, and user charges. And we include recommendations on what the country can do to strengthen financial protection. So all of this you can find on the country page. Now, if we go to the more dynamic or customizable options on the page, you can find here that there are two buttons on top, the Indicator Explorer and the Policy Explorer. So let's start with the Indicator Explorer. So as its name, so you can basically, you have a menu of the different indicators that we collect, and you can choose the type of indicator that you would want to look at, the country, and the year. So here, I think I've chosen, yes, the breakdown of catastrophic health spending by type of healthcare. We've already seen this, and as you can see, the red bits are medicines, and you can see that they're the main driver of catastrophic health spending across the region. And the nice thing is that there's a download button, so you can actually download this data and play around with it however way you want for your analysis. And next, we go to the Policy Explorer, which is the second option, where you can look at the different dimensions of coverage policy, be it population coverage, service coverage, user charges, also the changes in coverage policy. Remember that we collect many years of coverage policy changes for most countries. So here I've chosen Belgium. So Belgium, we looked at population coverage. This is the most recent available information in 2025. And you can see what is the basis for entitlement, who are the people who are not covered, etc. Everything is included on the table. Also the same, includes a download button. And then next, there's the comparative option, where here I have chosen to look at user charges for outpatient medicines in France, Germany, and Slovenia. You see that for 2025, you see the type of user charge, exemptions, and caps. So it really allows you to get a bigger picture, compare your countries, knowing that this is the latest available information that's there. And last but not least, we have the resources page. You can see that we have country analyses, but also comparative analyses with buttons showing you this publication relates to what exactly, whether it's financial protection, resilience, financing, or spending in this slide. Here, I have chosen to look at the comparative analyses, and you see here the two briefs that we've just published, who are actually gone from the table, so it looks like you were interested in reading them, but they're online on UHC Watch, as well as the regional report. And I'm almost done. Basically, how do we collect the information, specifically information on coverage policy? What we do is we work with around 71 senior experts in 46 countries across Europe and Central Asia to collect systematically the evidence or the information on coverage policy. And we do that in a very standard manner, so that in case you want to use that information for international comparison to identify good practice, you can do that by browsing through the Policy Explorer and the website in general. And as I said, for the policy changes, you can also find them documented over time on the website. Okay, and this is a slide to really thank the team, who without this, this platform wouldn't have been what it is today. They're probably following us online to Jorge, Maria, and Marcos. Of course, Mariana and Philip, our IT advisor, and Sarah. Thank you, guys. What is there? I know you're so excited to look at UHC Watch. I hope I've made you excited. Your phones, scan, please. No, really, I'm not kidding. If you want to scan the website, you have to scan the website. We want to see numbers rising. Okay, you will see that actually the phone version is still not up. We're still working on that. I tricked you. I tricked you to make you access the website. So just for you to know, you can Google UHC Watch. It's the first link that comes up. And make sure you disseminate this website of ours. Thank you.
Thank you, Lynn. That's so you now have no excuse for not going there, and you can do it on a proper computer instead of fiddling around with the inadequate size of screen here. So do it the proper way. We've been talking a little bit about the whole challenge of the potentially declining tax base and so on. John's going to talk through a little bit of what are the options around trying to produce a more stable and more sustainable system of revenue raising. And this will give us, I think, a little bit of a basis in the discussion in the panel to what are the options we can try and follow.
Thank you, Charles. So I was told by many of you that my presentation in the last session was depressing or gloomy. I think that Sarah said gloomy like 6 times. So I'm hoping this will be a less gloomy presentation, but no guarantees. So I want to start off, I guess it starts off the same way, so maybe that's not a very good omen for the degree of gloominess. But I want to start off with the first slide, the same one I had before, which looks at how countries that have more public spending as a share of GDP on health have lower out-of-pocket spending. And I said before how the outlook for the future is pretty grim for public spending. And then I stopped and I sat down for like 2 hours. And so I think this raises a really important question then, given that discussion. Well, how can countries raise stable, sufficient revenues for health? So that's what the topic of this motivating presentation, hopefully less gloomy, more motivating presentation will be. So if we're going to talk how do we raise sufficient, stable revenues for health, we need to first think about, well, where does public money for health come from? And so this figure, now I should say this is an estimate. So if you see your country and you say that's wrong, maybe. But this is based on internationally available data from the OECD, from WHO, to try and triangulate approximately the mix of taxes that are used in countries to finance healthcare. So in this dark blue color, we have social contributions, which we've heard a lot about, right? We should not link them to entitlement. They're linked to the labor market. Employers and employees generally pay them. These are not always, but usually earmarked for health. And in some countries like Poland, Slovenia, Germany, Croatia, there's a fairly high reliance on social contributions. The other forms of taxation that go into financing health usually are not earmarked for health. They're more generally represent the broader public sector, the mix of taxes that are used in countries. But we have in green taxes on income, in purple taxes on property, and in red taxes on goods and services. Mostly it's taxes on income and taxes on goods and services that comprise the bulk of public financing apart from social contributions. Okay, so why did I show you this? So what I'm going to do is I'm going to give an illustration of how the choices that countries make about how they finance healthcare or how they raise revenues for healthcare, how these affect their sustainability and in the end, how dependent that will make these countries on out-of-pocket payments in the future due to the lack of sustainability of revenue raising. And I will do this, we will do this using the PASH simulator. Have any of you heard of the PASH simulator? Lynn, Dirk, okay, not as many, mostly people I know. Okay, disappointing, that's fine. You can find it also with this QR code, although much like the UHC Watch one, I discovered this morning that it doesn't always work on the phone, but that's not a reason not to try. So the PASH simulator is a simulator that was developed by the European Observatory on Health Systems and Policies, together with the WHO Kobe Center, to look at how population aging affects health financing, how it affects changes in the age mix of the population affect revenues and expenditures for health. And the assumption here in the PASH simulator is that the way that we finance healthcare today stays the same forever. So spending by age stays the same. The mix of taxes, which is the main focus of this session, stays the same, but the age mix changes. So we'll have, as I showed in the first depressing presentation, the working age population, for example, will decline, and the share of population at older ages will increase. And so what I'll do is I'll show how revenue raising is potentially susceptible to changes in the age mix of the population, and then look at what would happen if there's a gap between expenditures and revenues as a result of population aging, and all of that gap is filled by out-of-pocket payments. In the same motivation as before, right? If we don't raise enough money for health, households are going to bear more of the costs of financing health at the point of use. Makes sense, right? Okay, silence is agreement. So to make this a bit more intuitive, I included this special slide, which underpins a lot of this model, and I think is important for the intuition when we want to think about the resilience of health financing, at least in the context of population aging. So this is an illustrative example of how different forms of taxation vary by age. So for example, in blue here, we have social contributions, which are, anyone know, linked to the, anybody? Labor market. All right, Dirk is mouthing it. Too shy to say it out loud, but labor market, exactly. And social contributions, of course, are very low for children, 0, children do not work. As people start to join the labor market, they start to rise, and then as people start to leave the labor market in middle age, later middle age, they begin to fall, and they're near 0 at older ages. Income taxes follow the same trajectory. Children do not earn very much income. They follow the same trajectory as social contributions in young adulthood, because most young adults, their wages are their only form of income. But then eventually, for some people, people start earning less from wages, and they have other forms of income, maybe from assets or investments. And so generally, at a population level, if we're looking per person, income continues to rise for longer, and so income taxation rises for longer, and it declines more slowly. In red, we have taxes on goods and services. These are fairly flat over the life course. So children consume a little bit less than grown-ups, and so they have lower taxes generated on their behalf through things like VAT. But generally speaking, consumption taxes are flat over the life course, and same for property taxes after childhood. Children don't have a lot of property. And so returning to this figure I showed before, what we do is we're going to look and see how, given these dynamics of how the ability to generate tax revenues from different taxes varies at different ages, we're going to see how does the mix of taxes that a country relies on affect the resilience of health financing, or the stability and sufficiency of revenue generation. And we're going to look at 2 countries, Slovenia over here and Spain. The reason we're going to pick Slovenia and Spain is because Slovenia is it's an interesting country because it relies very heavily, as you can see, on social contributions. So this is data, I believe, from 2022. Around 80% of public spending on health came from social contributions, and Spain, which is primarily general taxation. So we're going to see what happens from population aging. So this is a very a rapid fire look at this this analysis. Here we have the results of the PASH simulator. So in the dark blue color for each country, we have the per person expenditure. So this is indexed to 100 in the base year. The assumption is that revenues and expenditures equal each other, and then they start to diverge as the population age mix changes. And this divergence, this gap between expenditures and revenues, this is the financing gap that we're talking about that would be potentially paid for through out-of-pocket payments. Now, looking at this figure, you can't tell very much. The gaps are pretty similar. But if we look here, this is the gap in 2060, so the end of this forecast period, split between the gap attributable to growth in of more older people, and the gap due to declines in revenue, largely because you have fewer working age people. And so what you see is that the gaps are relatively similar between Slovenia and Spain, but in the case of Slovenia, about 1/3 of the financing gap is due to revenue raising, declines in revenue raising, Whereas for Spain, there's not really much of a decline over the next 35 years in revenues. So taking this thought experiment forward, we say, okay, how much would the average person need to increase their out-of-pocket payments in each year to fill the financing gap just for Spain and Slovenia? We see Slovenia has much higher increase. By the end of 2060, the average person in Slovenia would need to pay 2.6 times more out of pocket, whereas in Spain, it's about 1.9 times. This is not because of the size of the gap exclusively. This is also because of how much these countries already rely on out-of-pocket payments. So in Slovenia, out-of-pocket payments are very low. You may remember from Tamás's slide, Slovenia is, or you may not have seen, but it's one of the best performers in Europe in terms of catastrophic and impoverishing spending. And so since there's very little out-of-pocket spending currently, we're at baseline, it means that the multiple has to be bigger. You need people to spend much more to fill the gap. But if we look here, the change in financial hardship due to the greater out-of-pocket spending that would need to occur to fill the gap, we see again in Slovenia a much larger relative increase, still very low in terms of impoverishing and catastrophic spending. Well, at least in terms of impoverishing spending, in terms of catastrophic spending, actually quite large increases. Whereas in Spain, the increases are much smaller. And again, the gaps are very similar, but a lot of this, a third of this gap is due to reductions in revenue. So if Slovenia had a revenue raising mechanism that looked more like Spain, it would have much less growth in catastrophic and impoverishing spending. Obviously, there's going to be growth in health expenditure as populations age because on average, older people consume more health services than younger people on average. But the revenue raising really makes a difference. And just to highlight that this is not just about population aging, this is again is looking at Slovenia and looking at data from around the financial crisis about 10 to 15 years ago. And you can see here in pink, the unemployment in Slovenia increased. And in brown, the wages fell. And because you had more unemployed people, so a smaller workforce, and you had lower wages, the contributions, the revenues generated by the Health Insurance Institute fell as well, because it's extremely pro-cyclical in Slovenia. So whether it's because of declining working age people or declines in the size of the labor market because of an economic downturn, the ability to generate revenues for health in Slovenia is very susceptible to these sorts of changes, whereas in a country like Spain, it would not be. So, has Slovenia addressed the financial unsustainability and ultimately affordable access to care challenge? Well, kind of. There's been progress, but it's not solved. So, in Slovenia, historically, the data that I showed are from 2022. And at that time and before, in Slovenia, there were very high user charges for publicly financed care, but almost no one paid them because everybody took out voluntary health insurance. So nearly 100% of the population had voluntary health insurance to cover those statutory co-payments. And this was an artifact from many years ago of Slovenia trying to keep the size of the public sector smaller. So they created these high user charges and then have everybody paying for voluntary insurance to cover them. This was very good, in the one sense, because it meant very strong financial protection. But the voluntary health insurance, the premiums were flat for everybody, so they were very regressive because poor households and rich households were spending the same amount. And it was also inefficient because the money that was collected by these voluntary insurance companies could not be redistributed to pay for other healthcare, so it couldn't be pooled with the rest of the resources for health. So after many years of trying to get rid of this, Slovenia last January, finally abolished user charges completely. So there are no user charges in Slovenia. And now people must pay a mandatory flat levy. So the same amount actually as the voluntary health insurance premium. So it's still flat, still not equitable. But it's it's pooled with the rest of public resources. And so on the one hand, this is very positive because financial protection has been maintained. But on the other hand, when we think about the unsustainability of revenues, it's still problematic because the levy is relatively low, and there's still this very high reliance on social contributions to finance healthcare with no automatic mechanisms to transfer money from general tax revenues. So they've solved one problem, but they haven't solved the entire problem, because they still have this very high reliance on a revenue source, the working age population, which will shrink over time. And so, as we talked about earlier, and as we saw from the PASH simulator, there's a very good chance in the future that Slovenia will be under pressure to rely more heavily on out-of-pocket payments because its public revenue is still not sustainably financed. So how can health revenues be more stable in a country like Slovenia? And I give Slovenia as the example, but this applies to any country that has a high reliance on social contributions. This is not exclusive to the Slovenia case. So you can look at a case like Lithuania. We also heard from Czechia earlier of automatic transfers to a purchaser like a health insurance fund on behalf of the non-contributors. And I think Lithuania, at least historically, gave us a really good example of this, where we can see, much like we saw in the Slovenia case for contributions during the financial crisis, as people lost their jobs, we saw for Slovenia, wages fell, unemployment fell, contributions fell. In Lithuania, the same thing happened during the financial crisis, but the government budget automatically stepped in to try and maintain flat revenues, so the revenues didn't decline. And the reason this happened is because at that time, the basis for the transfers from general tax revenues to the National Health Insurance Fund was average wages. So average wages from 2 years prior, rather. So it was something that was not affected by the economic downturn. It was not based on minimum wages or the wage of some sort of very low paid basis. It was the average wages. And so the result of this was that it was good enough, it was high enough as a revenue base that revenues could remain flat. Now, since that time, more recently, Lithuania has weakened this mechanism, and I believe in Czechia it's similar, that it's coming from a low baseline, that the contributions on behalf of non-contributors that come from general tax revenues are lower than the contributions paid by contributors. Yes, Adam nodding yes. And so the same has happened in Lithuania, that now it's based on minimum wages. So this mechanism has been weakened. But I think this is an important mechanism to think about how to diversify revenues. This is my last slide, I promise, Charles. So the takeaway message is that it's important to generate enough public revenues for health to keep out-of-pocket spending low. I think we could have had that conclusion even from the first slide, that countries that spend more publicly rely less on out-of-pocket payments. But importantly, and I know I gave a lot of gloom in the first session, the approach to raising revenues plays an important role in determining the ability to generate revenues in a resilient, sufficient, stable way. Reliance on social contributions is very risky, not only because of population aging, but also because of economic downturns. And as we know, health needs from the population do not correlate with business cycles. And actually, if we think about aging and we think about that as you have an older population, you'll need more revenues, it doesn't make sense that you would rely so heavily on a revenue base that's shrinking at exactly the moment that you need to be spending more money. So I think diversification is key. Obviously, diversifying the revenues for health is tricky, and that's why tricky politically, and that's why I think this automatic mechanisms that are able to generate enough revenues to make sure that overall health revenues remain stable is key. And with that, I stop. Thank you. Hopefully less depressing.
But before, yes, you were allowed to clap. Yeah. He did a bit better this time. I think we have to. But hold the microphone a moment. Are there any specific questions to John before we move into the panel? There was one question came in on the chat, and that was about the role of inflation in the sustainability of healthcare finance. I wonder if you've got any comments on how inflation may affect things one way or the other.
No, I mentioned this in the first session, talking about efficiency and how economy-wide prices make it, how many countries during the financial crisis, were able to achieve efficiency gains by reducing the prices that they pay for services or the prices that they pay for medicines. And that is likely very difficult in the current environment because of the high inflation that has occurred across the world in the last 2 years, really. So I think, I mean, it's tricky, obviously, with the point I wanted to make before about the high inflation was that it's very hard to reduce prices. At the same time, in most European countries, there's a single purchaser or a small group of purchasers that do have the ability to dictate prices. And so I think, especially in countries that are larger, where there's a single purchaser, where they have ability to steer the market, then countries do not need to purchasers do not need to update their prices on a one-for-one basis to adjust for inflation, but they need to take it into consideration. So I think it's a very not precise answer, but I think that health systems do need to make some adjustments to account for inflationary pressures, but that they can resist some of the temptation to adjust fully.
One more question from Josep Figueres.
Oh no.
You
yeah.
slightly, yes, Joseph, yeah. You slightly lift our moods after the gloomy presentation.
Thank you, Giuseppe.
However, John, what you suggested now is your scenario number 3, which is budget reallocation, because clearly taxes will not go up, general taxes. Therefore, you said to us, well, the money goes to defense, and that's very unlikely. So where are we now? I mean, I think we go back to what Sarah was, and all of you put on the table, which is one of the oldest arguments, which is demonstrating the usual, that for a resilient economy, we need to keep those in the in the labor market, that if they fall because some user charging onto the system, are very difficult to bring them back. So we are going back about how do we communicate and link this stuff with the Draghi report, to the letter report, which are now the fancy stuff that we all talk about in the European capital. So I think that's the next step. I think your presentations are absolutely amazingly brilliant, very good. We have all the arguments, and now is how do we move to the next level and tie all that to the main economic sort of debate we have in the EU that I'm sure Dirk will be talking in a minute, right? So
yeah. No, Giuseppe, I think it's a good point, and obviously you're right. There is the inherent contradiction that I think that budget reprioritization in the broader public sector is tricky, given these newfound priorities like additional, God bless you, additional defense spending. But you're right that ultimately that's the mechanism that countries are going to need to rely on, and the only way that will happen is if countries recognize the value that comes from investing in health. And so, yeah, I could have made this another presentation of how do you achieve that? How do you make the case? Because there are countries like Slovenia that are now trying to figure out how do you create these automatic mechanisms to transfer money, and how do you get that through politically, right? It's not just about saying, okay, then we will contribute X number of euros on behalf of every child or every pensioner. It's the politics, it's the political economy factors of how do we make the case that doing that is a good use of resources. And ultimately, like you're saying, if public sectors are not going to grow in the short to medium term substantially, it will mean taking money from other things. And if we could think about, I don't want to be up here suggesting what we should take money from, but we have declining numbers of children in many countries. I mean, I have children. I think we should still pay for schools and children, but the needs change with the population, with the age demographic changes as well. So I think there is probably scope for reprioritization, but it takes a lot of political will to argue for it.
Got one or two other questions come in on the chat, which I think will do well in the panel discussion. So thank you, John, for not being quite so depressing this time as you were the last time. Now, can I ask the 4 panelists then to come up? We've got Sarah Thompson, Adam Ander, Ewout van Grinniken, and Natasha Azzopardi-Muscat. Now, we've got to the interesting part of the day, you know, how we can be forward-looking, how we can be thinking about how we meet these challenges, what are the questions we're really going to ask. And it's really, I think it's important to try and start off with one or two of the more fundamental questions, like, are we really right to say that the fiscal space, so-called, is limited, when the alternative to the fiscal space being increased is that people pay out of pocket even more for the same thing? Now, I started teaching macroeconomics, I'm sad to say, in 1978. One or two of you were not born at the time. And at that time, I learned that the reasons why you were worried about the size of the public sector was the content of spending in the public sector and why that might displace more productive spending that might come in the private sector. If the reduction in taxes leads to an increase in unproductive private expenditure, and that increase is bigger than the reduction in taxes, that makes absolutely no sense. What you're doing is saying, let's make life miserable for people, make them even poorer than they would be, and produce no difference in the access, in the quality of care, but reduce the access. So there's a sense in which I think we do need to be questioning at one level, is it sensible to say, let's do the same thing but do it worse? Or is it better to have the alternative view that in this circumstance, the alternative to more public spending is a worse configuration overall in the economy? I just give that as my old-fashioned 1978 view of the world. Funnily enough, the world has not changed all that much in the intervening period. But I put that on the table because I'm sure all of you feel that there is some sort of constraint there, and maybe the constraint is pretty strong. But I think part of the argument probably has to be why that constraint doesn't make as much sense as many people think it does. So just let's start off with a little bit of thoughts from the panel. How can countries sustain progress towards universal health coverage in the light of tight financial constraints? And seeing as Ewout has got something quite different to talk about, I'm not going to ask him first, but we'll start with Sarah.
Charles, see, that's a big question, and I'm just going to focus on some country experience here. So John told the very nice story of Slovenia, and we like the Slovenia story because Slovenia recognized that they had a problem with their coverage policy, and they decided to do something about it, and they actually did something about it, and that's always a great thing. So they addressed their coverage policy problem, but when it came to addressing the revenue raising problem, they stalled. They know they have an issue and they're trying to do something about it, but we're not sure how far they're going to get right now. But they do need to address it, because if they don't address the revenue raising problem, then as John said, ultimately it will become a coverage policy problem again, because waiting lists and waiting times will go up and people will end up paying out of pocket in one way or another. So I want to just reflect a little bit on the French experience, which we haven't covered today, because I think it's a useful example for Slovenia in particular, but also for countries like Czechia, a lot of other countries with social health insurance schemes in the EU that rely very heavily on the labor market to finance healthcare. And I think the French story is really worth highlighting. It has some very interesting lessons from a number of countries. So this is going back to history here. In the 1980s, the French saw that they had a problem with coverage policy and with the levy base for the health system, and they decided to take action. But the problems were that because social health insurance contributions are really closely linked to employment, there was a universality challenge. So if you were unemployed, or if you were between jobs, or you had insecure employment, changing from one job to another, it was very difficult for you to be covered. And they had a problem with youth unemployment in the 1980s, and they thought, actually, this is not very sustainable for the future, that we have quite a large share of the population that is in and out of coverage all the time. It's very distressing for them. They also understood that they had a very narrow revenue base, and it was very cyclical. And it was also increasingly unfair, because it was very much focused on labor market, on salaries, on wages. So workers were paying a lot of their income in social insurance contributions, but other people, income from capital, was not contributing to the welfare state in France. So a universality issue, a narrow revenue base, fairness issue, and this is a bit that I really love. They looked at the future in France. They looked at the demographic shift, the aging of the population, and they understood that if they were okay today, they were not going to be okay tomorrow. And the brilliant thing is that they took action that was going to be revenue neutral today, but was going to bear fruit in 5 years and 10 years, so actually beyond the political cycle. And that's quite unusual. Many of you from countries will understand it's an unusual thing that they did. So what did they do? First of all, they broadened the revenue base, and John didn't talk about this in his presentation. He talked about increasing government transfers and having mechanisms in place to increase and stabilize government transfers to the health insurance fund. But they simply broadened the revenue base of the social health insurance contribution from employment and wages to all types of income, including income from capital, income from gambling earnings, income from pensions and unemployment benefits as well. So this was a huge change that they made in 1991, so quite a long time ago. And it was seen as something that was much fairer because it was capturing a much broader income from a much broader sphere of the population than just people who were in work. And then in 2000, they changed the basis for entitlement from payment of contributions to residence. They kept their social health insurance scheme, they kept their social health insurance contributions, but they broadened the levy base and they changed the basis for entitlement. And then in 2016, they took the final step and they said anybody who's a resident in France can be permanently covered. So you're automatically covered, but you're permanently covered, whereas before people had to when they changed job, they still had to register and so on. So I think a useful lesson for Slovenia on a different way in which countries can address this fiscal sustainability issue. Just one last thing I want to say on France is that they address the revenue raising problem very beautifully in France, I think, and in a very foresighted manner, but they haven't really addressed their user charges and their voluntary health insurance problem, and they have a very complicated market for voluntary health insurance in France that I won't bore you all with the details of, but suffice to say that actually now France, interestingly, Slovenia copied France in the early 1990s when it set up voluntary health insurance to cover co-payments. So France was the OG, the original, using voluntary health insurance to cover co-payments, and now I think that France could learn very interesting lessons from Slovenia on how to address their coverage policy challenges when it comes to user charges and voluntary health insurance.
Adam, from the sort of coalface that you've been looking at, and the experience of some really important problem solving in Czechia to try and address some of the difficulties, have you got any additional thoughts on how we can try and ensure that the system remains sustainable?
Well, most of my thoughts were already mentioned. It was mentioned that we have quite good working transfer of funds from the state budget, but obviously, as it was pointed out, the state budget is not unlimited. And we are trying to find other solutions, and they were mentioned by you. We are trying to figure out if there are some possibilities of changing the base from which the contributions are calculated. And there are, let's say, different bases for different groups of population, and we want them to be in line in the future. And we also are thinking about introducing a contribution from property incomes. And this might help us for some time, so we will probably get some time more.
Probably don't have property for longer than you have young people, so that's probably a good thing. Natasha, would you like to add anything from your broader experience across the region, as well as possibly from your experience in Malta?
Thank you, Charles. So perhaps I'll start with something that had surprised me a very long time ago, I think probably close to 20 years ago in Malta, when we had a minister who had suggested that we use VAT earnings to support healthcare. And at the time, I think we were wondering where this came from. And I'm not certain whether the link was ever made very, very explicit, but clearly, I think there was some foresight over there And we saw that there's this predominant increase in tax spending, and this gives you a kind of flexibility when it comes to the older population, as John said. So I was just reminded of that and thinking that maybe we also need some new thinking. But I'd like to bring a couple of other elements into the mix over here. The first thing is that this is one of the only meetings I've been to recently where I think we haven't really been talking about AI and how AI is going to change the system. And on the one hand, it's very refreshing. But on the other hand, I think that we need to be thinking of this when we try to think about what expenditures are going to look like and what we're going to have to continue paying for. And this is linked to the fact that the labor market is going to change. It's going to change very rapidly. And that's going to mean that the people who are going to be able to pay and to contribute, it's also going to change too. It also means that we might end up being one of the only sectors where we still have quite a heavy reliance on human inputs, because we know that a large amount of care, actual care, is not substitutable. And some time ago, somebody asked me, he said, what is this why are we kind of capping ourselves and saying it's impossible to have a larger proportion of the workforce working in health than we have already, when so many fundamental changes are going to take place? So in this same vein of reasoning, and coupling this, and this will be kind of my final wrap-up point, which is the politics of all of this. We are talking about technical solutions, but these are not technical solutions. These are inherently very, very political solutions that are being spoken about, that are being put on the table. And therefore, when we are looking at these political solutions, when we see also what is driving people to vote in certain ways, the one thing that I haven't wrapped my head around completely is that in many countries, it's those people, and we know, we have evidence from colleagues in the observatory who have published on this topic, who are being left behind, who are not getting the access, who are having to pay out of pocket, who are suffering the consequences, who then respond in a political sense. And why haven't we been able, therefore, to come full circle and convince politicians that we may need to put more money, and it may not be the right form of reasoning to have this kind of cap, if this is an area that people want to see more investment in? So it seems to me as though we need to bring this political dimension in, and we need to understand that the system that we are putting money into is going to be changing probably quite rapidly, and this will require us to adapt our financing systems more rapidly than we have been able to do so in the last half a century or so. So I don't know if that brings anything helpful or opens too much up, but no, that's kind of what I've been reflecting whilst listening.
Without us conspiring on this, you've actually raised some of the points I wanted to put to Ewout. There was a very interesting question in the chat, and that was, why do we measure access rather than measuring effect? You know, why are we concerned about getting access to care rather than whether it does anything useful for us? And I think, could you talk a little bit, perhaps, about some of the thinking around how we just do the job better than we've done in the past in order to make up that space that would otherwise not be there?
Yeah, I think that you need to discuss not only, okay, today we're focusing really on the financing side, the resilience and the sustainability financing. But I think you cannot approach a policymaker with only that. You also need to really talk that you show to purchase the goods services for that money and that you are seen to be spending it wisely. So I think these two go hand in hand. And yeah, the way I would see it is, first of all, and I think that is politically, I think, attractive, you should focus on, you know, getting rid of low value care. We had the nice report together with the expert group on HSPA that we supported, and where we show a whole framework how to approach this issue. And I know that we still miss data and quality data to really do so, but it's an area that we need to develop, and where we, you know, there's lots of potential, not just underuse or overuse or misuse or you know, lots of geographical or by any other strata, you know, variation that you can address. So I think that is one of the first things you need to talk about, and I think that also plays well politically. And then you need to also talk about the new models of care, the transformation that we need in our health system to better care of the demography of tomorrow. And well, today we're talking about aging a lot. Aging per se is not the issue. It's perhaps much more, you know, proximity to dying. And we know that if people die in much higher ages, the associated cost is lower. I don't know if this slide was shown this morning. I wasn't here for the first gloomy presentation that you gave, John. That means that we need to have a system that manages to keep people healthy in older ages. And I know that we've been saying this for a long, long time, but we really need to act on it and, you know, develop those models of care that really have this holistic view. And I think it was mentioned, I think, from the audience, which is a really valid point. I think we're still way too siloed. We are still way too disease-oriented in many of our approaches, but we need to look at a person in his environment with the services available around him or her, including social services. So I think this needs to change in how we approach it, and also requires a different, funding models. And there are a couple of things here to look at, I think. Of course, we need to see how we can bridge between health and social care. And that is something, again, that we've been talking about for a long, long time. And some countries are making progress here. Finland has integrated budgets for social and healthcare, whereas other countries still have that struggle between these two and coordinating between these two. It's maybe not just a matter of just putting them together. Maybe that is really difficult. But also, how do you integrate, I don't know, between the health and the social care system? For example, think of social prescribing or social participation as instruments to achieve that. And how do you pay for that? What kind of payment mechanisms do you need there? Then I think when we had discussions with payers in one of our webinars we had on integrated care, this was a very innovative model from Germany. And I asked the person, what did you learn in the last 20 years implementing these models? What was your main lesson? What was your main obstacle? He didn't say, oh, the payment model or you know, the certain specifics or workforce. He said the missing long-term perspective among the payer. That still payers are very much focused on 1-2 years instead of a longer perspective where, you know, maybe it costs more at the beginning and in the end it will pay itself back. There is no long-term perspective here, and this is something that we don't do enough, obviously. So, you know, that is another issue that I think is very, very clear. Maybe I'll leave it here. I can talk much more also about the kind of payment mechanisms needed to achieve this, but maybe there are questions and we can go into that more.
I think that's very, very helpful. Most of my work nowadays is on palliative and end-of-life care. And one of the things we have found is that decision-making and planning and forward planning are absolutely central to getting a good trajectory of care. If you don't do that, people bounce around in the back of the hospital, nobody in charge, nobody quite sure what to do. This is a version of integrated care, but it's actually thoughtful care. And we were able to show, for example, that by putting a palliative care person into an emergency department, you could lower the average cost of what followed by about €10,000. Now, that's only a specific group of people who have chronic complex needs and so on. But instead of them going in and out and up and down and every assessment done again, they were put together a plan on how they would live out the rest of their life, and you got better outcomes. You got better outcomes and you got better and much lower cost. That's, as I say, it's a small group of people who you could identify as having very specific problems. So I think the scope for doing what we do better is enormous. The challenges of doing what we do better are enormous as well, but I think that's good. Now, I'll take one or two questions or comments from the floor. I've got one or two other things I'd like to ask the panel, but I'll take here and here. If you just say who you are, you've already said who you are, but you can say again because it was worth listening to.
Natalia Hraszkiewicz-Birkemeyer, I'm a scientific expert for the European Commission. Just one remark, I think all these discussions are very relevant, and I think we should think about next steps. For example, how to measure our results, how to measure improvements. For example, in terms of indicators, and the European Commission has certain European core health indicators. There are also indicators proposed by WHO, and we have an excellent report recently released by the Global World Bank, which relates to financing of health care, which refers, for example, to public expenditure reportings. And there are also several indicators mentioned there. So I think it's good to have some more insights and to agree how to measure our progress. Thank you.
Thank you. I'll take the next question as well before we ask for any responses. Does anyone else want to be in the queue while we're waiting? No? Carry on. Sir.
Okay. So I wanted to talk about what we consider affordable access to healthcare in the conditions that we know currently, meaning that how do we talk about staff shortages and how that isn't sustainable at all, considering that more funds need to be dedicated to the healthcare workers. And also I was curious about how we calculate unmet needs, because I was surprised about how low they were. Like, for instance, I come from France, and I know that there's a massive shortage in psychiatry, but sometimes this is not reported as there are not patients. However, these people really need care and they can't afford it, mostly because there are, again, because of the shortage. So yeah, I was just curious about how do we calculate those unmet needs, if possible.
I think that the unmet needs, a question has come in on the chat about unmet needs as well. I wonder if anyone would like to make a quick comment on unmet needs. Perhaps about you, sir?
No, I believe that you're right, that it's often an underestimation, because the way that these surveys are done, it doesn't capture the whole population. And there are people here in the room who probably know even more about this. I'm looking at you, Kasia. For example, homeless people. So I think they're not included in some of these surveys. So I think that what we see is perhaps not always realistic, and what people somehow feel. And if you talk to doctors of the world, what they see happening in their practices, which are really treating these people. So I think that this is a role, I think, for Europe, where we can do much better in terms of, standardizing this data. It is standardized, but improve these surveys so that they paint a more realistic picture. I always am amazed by the number that we have for the Netherlands, an unmet need. If you would tell it to a Dutch person, they would think you are joking, because they feel like, oh, we pay a lot and we have a deductible, 385 euros, etc. So clearly, I think that there is room for improvement here, and I think it's really about expanding the scope of the survey.
And Sarah?
In response to the question about how do we measure progress and data, I think this is exactly what we have been trying to do in this project here, finding ways to measure progress on affordable access to healthcare and finding indicators that are actually sensitive to policy changes sensitive to what's happening among people with low incomes. And you mentioned the World Bank report on health financing, and of course, I'm sure that's very good, and there are lots of health spending indicators that we can use, but these indicators of health spending do not tell us about the distribution of health spending. And that's where, in this project, we have really gone beyond that, using household budget survey that give us data on which households in the population are experiencing financial hardship. The unmet need data also have data by quintile, which households by income, by all sorts of other disaggregations, age, employment status, and so on, are experiencing unmet need for healthcare. So I think in this project, we have really been able to go beyond what are traditionally considered to be health financing indicators and pinpoint the types of households that are experiencing financial hardship. And we can measure progress over time in countries, and that's what we are doing now. I think the job for countries and maybe for the European Commission also is to make sure that these data, these micro data from household surveys are available on a regular basis and available to researchers also. So I won't bore you with the details, but sometimes it's incredibly difficult to get access to these data from countries. So I think this is something that we are very conscious of, and it's a real contribution that we think that the project has made in actually making progress on the types of data and monitoring that we're doing.
You have a point.
Very quick comment. It starts from staff shortages. Because of staff shortages, in some countries, the publicly funded healthcare systems are suffering. We see also some internal migration from public services to private parallel services, not private contractors covered by the social insurers, but totally parallel systems. And this in turn is also then playing out when it comes to people trying to access the system and having to pay additionally to what they are paying into the compulsory systems. And this is the main reason why I think we need to keep monitoring financial protection, because it's not just about coverage policy, but it's about how effective that coverage policy is on the ground. So it goes way beyond the macro indicators to whether you are having the impact that you want to be having on people's lives. So this is really an indicator which is very important for politicians who want to get re-elected.
I just like to pick up this staff shortage question a little bit, because we live in an age of 19th century health professions. They emerged in the 18th and 19th century, and we fiddled with them at the edges a bit, but we haven't done very much about them. And I would argue, certainly, that we really need to have a much more serious conversation about how we bring the health professions into line with the needs for the provision of care. I wonder if any of you got any thoughts or comments on that. Any of you, I don't know who's better than anyone else. So Adam, you're allowed to be first.
This is not exactly comment to your thoughts, but it's also about staff shortages. This is also a challenge for Czech health insurance system, the public system, because if we want to retain our professionals in Czechia, we have to pay much more than we usually pay, because otherwise the health professionals go abroad. So we are losing them. This is one thing. And then we also have challenges in national environment when most of the healthcare professionals are in the cities, in the centers. And somehow, if we want to provide healthcare also in the countryside, it's also a challenge. And this is something that costs you additional money.
That's the very serious, there's internal migration, and then there's international migration, and there's sectoral migration, all of which are making it more difficult to provide the public service. I remember a public health doctor in Hungary in the early days afterwards. He came from, I wasn't sure if it was Szeged or Pécs, but he said, we are in the periphery of the periphery of the periphery. And except his English wasn't quite so good, so he said, we're in the periphery of the periphery of the periphery. Took us some time to work out where he was. Anyway, yes. Any thoughts on this, Sarah or Ivan?
Yeah, if I may. No, it's a very good point, but I have, well, we cannot retain, retrain, or recruit our way out of the shortages that we see. There's clearly this need for new care models, and I've talked about those before, specifically also those that manage to relieve the workforce. And the way we now appraise models often are against traditional triple aim, for example. You don't really look at the ability, perhaps, whether it can really relieve the workforce, and perhaps that should be a way to evaluate as well. So I think, what do you need for that? I mean, in terms of the workforce, what we've seen in you know, what makes these integrated care programs work, for example, is that you need to think of new training and new roles, also with interprofessional curricula where people understand each other's roles, that they can work better together as teams across silos as well. You know, just to name just one example, but there are of course many new roles, you know, visible in different spaces. But there is no one particular role. It's always very context dependent on what you need and what kind of a tradition you have in the system. But obviously, there are huge barriers there, you know, traditions and attitudes, etc., that you need to deal with to overcome, you know, some of the skepticism in introducing new roles and doing things differently.
Thank you. Any other questions from the floor before I... No, one of the other things that's come in on the chat is serious concern. Oh, sorry, I will come back to you in a moment. Serious concern about the incentives that removing all user fees are doing. And I just wonder if we could have some final sort of summary of what the evidence is about incentives and user fees, because I think it's important not to leave that as a loose strand, but perhaps Sarah's more in a position to answer that than others.
It's a good question. And I think the concern from policymakers is that if you make medicines or healthcare free, then people will use more than is appropriate, because if something's free, people like to have a lot of it. And I think this has been really quite roundly debunked by a lot of research evidence that's very systematic across different types of research studies. And in fact, when we look at what drives healthcare costs, it's really inappropriate use of healthcare. It's really what's happening on the supply side. And this great report that you mentioned, Ewout, on low-value care was very clear about this, that if you want to address low-value care, there are things that you can do that are really centered around what providers are doing, and not really on the patient side, at least when it comes to financial incentives. So I think the evidence is just very clear that if you are concerned about inappropriate use of healthcare and healthcare resources, then it's what happens on the supply side that you should be really focused on.
I think that's clearly what the body of evidence says, but there's also a good body of evidence that incentives on the supply side are hugely important too. Just as a simple example, we know that in Ireland the C-section rate for private patients is much higher than for public patients, but we also know the outcomes are no different between the two, except for more people having surgery. And it's a coincidence, obviously, that the surgeons get paid more for doing a C-section than they do for a normal delivery. Or it may not be not a coincidence. Anyway, we'll have this question, and then, as always, I will defer to my friend Josep to have the last question.
Thank you. I'm Dina Papartita from EuroHealthNet, and I wanted to ask about well, here we talk about public funding, and of course, this is the main source, and the government is responsible for providing healthcare, also preventive services to the population. But what about these more innovative ways of financing, looking above what the public money could do, looking at social outcome contracting or social impact bonds? Are there any ways that you could support countries to have? We know that health promoting services or projects may be small, and we know that for investments they're looking for big tickets, big projects, and how can we look, beyond what is available at the public spending level? Thank you.
I'll let Josep make his comment or question, and then a final run through the panel.
way that the strands are coming together in this panel. Ultimately, our worries is the outcomes, the health outcomes of all that. So, you know, by going to poverty, you affect your outcomes. There's the issues of unmet need. Ultimately, there's no unmet need when there's no value-based care. So the questions is now, is how do we bring those strands together in a way that the policymaker understands how that works? And one area that Sarah, you and I have been discussing, and you guys are doing extremely well, and yet not because of you, we need far more development, is the area of unmet need. You've been talking a little bit about that, but we are measuring that very poorly. Because I want to know about those who decided not to forgo treatment, not to get impoverished, because ultimately what's best to get impoverished and get affected or forgo treatment. And I want to understand those unmet needs that we have from the silk, that is such a fundamental, we are using that data all the time. I still don't understand what it means. But it's very good. I'm not looking at you, Dirk, because actually I like to highlight that this has been a very influential piece of indicators, and I use it all the time, but we still need to know much more about those who forgo need, to forgo care, and are unmet, and how that affects the health outcome, and how these elements come together to ultimately sell the case powerfully to the policymakers to hopefully reallocate money there. So I don't know, it's a question of reflection. I had to say it. Thank you.
I don't know either, but it could be either. But I'm going to let each of the panel have up to 15 seconds of final reflection on any of the points brought up.
On the innovative financing, thank you for raising this question. Yeah, I mean, it would be great to have innovative health financing mechanisms that actually worked and did the things that they were supposed to do. But I think there's very little evidence for these things like social impact bonds and other things. Maybe they will work in the future, but right now there's I think there's a lot of expectation, but not much delivery in reality. So I think that, as Joe Cutzon, one of our colleagues, has always said, health financing should be boring. We know what works already. And I think that one of the things that we can, public spending, John and Giuseppe, you raised this issue of reprioritization prioritization of the health budget. That's very important. But I think that rather than wasting time looking at these innovative health financing mechanisms, maybe if ministries of finance have the energy, they should be looking at improving the tax system that we already have, because many of the good things that we want in life can only come through a government that is really well resourced. And I think looking at the fiscal constraints, the gloomy picture that E or John painted this afternoon, I think that actually investing in a better, more effective, more efficient, more fair, more redistributive, more in line with health and well-being tax system is what may give us more of some of the things that we want.
Adam, a final reflection?
Yes,
15 seconds on that
reflection about unmet needs. It's always extremely necessary to check the data. We had an issue recently in Czechia when there were news that millions of people doesn't have their GPs and kids don't have their doctors. And then we asked the health insurance funds to give us data, and it was not the case. The number of people without GPs was very, very small. So check the data.
Okay. About
Not much to add. I agree also with some of the points made. I think that in terms of EU Silk, what we've been talking about, I think we had very concrete recommendations in the report that we did with the expert group on HSPA on how to potentially improve it. But it's also not easy. Then you could use it much better to target, you know, who is having an unmet need. Is it a specific group that is identifiable? Can we do something about it? That would be, I think, should be the goal, and I think it is the goal, right? So I'm positive that we hopefully get there one day.
Yeah.
So I think perhaps a bit of a response to Giuseppe's comment also. We need to become better at persuading policymakers to invest in preventive care, not just in the very, very flashy high tech. I think there is still a huge gap. This is the gap between aging and aging in good health. And when I'm talking about preventive care, I'm not necessarily talking about very upstream, but I'm talking within the health system itself at all stages, which probably we can coin the thoughtful care pathway.
I think that's been very helpful. I'll just, because I love this example, when the financial crisis hit Ireland, a small charge was put on all prescription medicines, even for the poorest of the poor. The interesting thing was what they stopped taking. And they stopped taking antidepressants, and they stopped taking blood pressure lowering drugs. And the thing about both of those is neither of them are very nice. I don't know if any of you have ever been on drugs that lower blood pressure, and I have. And it's high blood pressure is great fun. Low blood pressure is kind of nasty. But people self-medicated away from things that were hugely helpful. And I calculated that the number of strokes that were increased by that small charge was so large, and the care costs were so large, that it was hugely self-defeating. But I think the reason I give that example is it's very complicated to think about unmet need. And I think Sarah's absolutely right. We need boring finance, and we need really thoughtful understanding of the consequences of different patterns. So it just really leaves me to thank the panel. They've done a pretty good job, and I think they've helped put this to an end. And finally, we are privileged to have, yes, very privileged to have Dirk van der Steen here to say a few words, and Tomasz will be saying a few words. I won't introduce them separately. They can do their own duo dance on this.
Thank you very much. So the privilege and the pleasure is entirely mine to close today's policy dialogue together with Tomasz. And you'll see the kind of dance we put on the floor. For the time being, I'm dancing solo. I think what I heard from Sarah basically was a heart wish. Make health system financing boring again. Let's summarize it like this. But without kidding, at the European Commission, which I represent, and notably DG Santé, and we're very proud that we managed through our EU for Health program to support everything you saw here today. We certainly do agree that access is crucial. I mean, it's true what I heard from the panel. We have all the work on HTA, mainly at national level, but also at EU level, which serves to say, is something effective? At national level, is it cost effective? But what does it matter at the end of the day if we agree on a basket of benefits that are not low value if we don't have access? So certainly we have the principle 16 in the pillar of social rights, which is indeed about access to healthcare. Now, 2 points that came forward very strongly. One is, so we need to transform knowledge into action, and I heard no more excuses, the data are there, get moving. So what we saw here with the project is the potential of the data. You saw the UHC watch. You not only have the data, you have the narrative. Of course, the narrative is way more complex, we know this, but this is a good way to start scratching, and this is why you find the most effective way into building this complex story. So I hope also that the policy dialogue today inspired member states then to take up action, and I certainly found some of the experiences that were shared very inspiring. It was not only just gloomy slides, John. And you were not gloomy all the time, John, either, so that's fine. I heard tax the rich, basically, right? Am I wrong? But of course, we also need to unravel the complexities. We need to come up with strategies that are proactive, no longer reactive. And there too, there's a number of elements that came forward quite strongly. So strengthening the health financing systems, we need them to be fair, we need them to be efficient, sustainable. So we need to pool risks and resources across populations. And then there was the more holistic point. We need to also invest, not forget the focus of the budget, prevention, primary care. And I think that's also clear. That's our agenda in the European semester, by the way, which we've been pushing for many years, building on many, many data, including data that have to do with what is the public share of spending. What do we see mortality at working age? And we're also building the story about Josep. How do we convince our paymasters? And that's a story also about productivity, but that is not the first reason why we have healthcare. We have healthcare because we want to be healthy, we want to be happy. But we also have very beneficial spillovers, we can be productive, and we need to underscore these spillovers better. And for this we use, for instance, our European semester. solidarity, the fairness, the risk pooling, and the harnessing of technology, so the AI, so that we don't end up with the solo paradox for the macroeconomists, basically saying, I see computers everywhere except in the productivity numbers. Where are they in my GDP? I hear AI everywhere. When will it help push up productivity on the supply side? And beyond today's project, the EU does a lot more to address these complex challenges. I heard it starts with the workforce shortages. We certainly, for instance, have a joint action with the member states' heroes on planning, workforce planning, very crucial. And this builds on previous work, which, for instance, helped us, and this is also about the data and the unmet needs, helped us in the past to really convince Eurostat we, for instance, need data on the age breakdown of nurses, because 10 years ago, we did not have it compilated on Eurostat's website. So bit by bit, we're getting there, and we're building indeed on projects like today's, like the joint action on workforce planning that we use as arguments. We really need this. This is crucial. This is missing. We convince you, you convince the member states. So it's not all gloomy. We have reasons to be optimistic. We can act and we can deliver. On workforce, we also work with Be Well. We have projects on curricula, on basically updating the curricula for, among other, the digital transition. There we are again. And in the past, we also worked on medical deserts. And we have a big action on nursing with WHO that has to do with recruitment and retention. So there's a lot in our program. And I will stop the commercial here, Tamas. But I want to conclude. So if we look at all the challenges we face, the demographic shift, the need we have to curb the demand curve, the changing nature of demand, the chronic diseases, the risk of shocks, the challenges it puts to resilience. They're all complex and interwoven, but they're not unsurmountable. So the solution will lie in our ability to collaborate, to innovate, to be creative. And we start by saying, what's it all worth at the end of the day if we don't have access to it? So thank you very much, and thank you for today.
Thank you very much, Dirk. It's 3 minutes after 5, so I think I should be short and sweet. To me, health financing is definitely not boring. And I think it's going to be very difficult to make it boring when we come with messages like, you know, why is it that we cover medicine in hospitals, but not once patients leave hospitals? And, you know, some of the audience, some people in the audience, not here, but online, have the idea, what a great idea. Let's not cover medicines in hospitals. What a saving we can make through that. The other idea, why are you denying access to healthcare to those who don't pay their contribution when we don't deny access to those who don't pay their taxes? What a great idea. Let's deny also access to those who don't pay taxes. So there are these reflections on what we are saying. So I don't think it's going to be ever boring, but I think the fundamentals need to be boring. And I very much agree that, you know, some of those thinkings about, you know, how other ways could lead to a better and less challenging task for governments, they all lead to eventually to more private spending and at worst, you know, more out-of-pocket expenditure. So I think it's really important to have this evidence and not just have it, but put this evidence to work, because a lot of this is challenging conventional thinking about what works and what actually health insurance or social health insurance is about. I'll stop here on the content part, and I just wanted to thank the European Commission, DG Sante for this project, but let me extend it also to DG NEAR, DG Enest now. Enest, it must be also digital, right? That's why it's the new name. And also, let me also thank the Catalan government, which, you know, provides the basis for our functioning in Barcelona, and apparently they continue to do so. So we hope to continue this work because we cannot stop here. And thanks very much, Natasha, for your introduction, that this cannot be just considered as, okay, we are done with this project. And hopefully there will be sponsors to support this. But eventually, I think we need to go back to the core business. And that's, at the end of the day, it's responsibility for WHO to produce this public good, a true public good, because once it's produced, it's out there. And that's why we created the UHC Watch platform. It's out there. It's a public good, and we need to maintain and continue to produce this evidence. So with that, let me just thank everybody who attended here and also online. We had hundreds of viewers online. And sorry for the inequity in terms of how many questions and comments we incorporated from the online audience. But it's been great to have them also viewing us. And thanks very much, Charles, for coming all the way and also leaving soon to Helsinki, as I heard, to moderate this session. We've been privileged to walk together with Charles over the years, guiding us, and all of you in the panels. And I would also extend this to the whole network of the Financial Protection European Network, more than 70 people, I think, who 71, sorry for that one. Yes, leave no one behind. And I think that's my last comment. Thank you very much for coming, and have a very good evening. We certainly will have one. Thank you.